What a
Hello
pleasure.
and good evening, everybody from Jagsonpal. We are excited to begin this E-Conclave now on Anemia Mukt Bharat E-Conclave, which is organized by Association of Obs and Gynae Delhi in association with North Zone Societies. We are very pleased to welcome all the delegates and all the esteemed faculty that have gathered here today for this E-Conclave. This E-Conclave is brought to you in association with Jagsonpal Pharmaceuticals as the technical partners, as Jagsonpal Pharmaceuticals are the makers of Jepitone iron syrup, Doxypal DR-L doxycycline 100 mg capsules, and LycoRed Preg sachet of L-arginine, lycopene, and DHA. A very warm welcome to all the delegates. We now hand over this session to our convener, Dr. Komal Chavan, ma'am. She is the immediate chairperson of Medical Disorders in Pregnancy Committee of FOGSI. Dr. Komal, ma'am, please.
Thank you so much, Dr. Deepika. And it is really a proud privilege to associate with Delhi Society and the North Zone for this very, very focused topic of anemia. You know, anemia, Mukt Bharat is a dream, and we are striving our best all throughout so many years to achieve Anemia Mukt Bharat and anemia-free pregnancy. And today specifically is a day, the 26th of November, is an iron deficiency day. And we have been raising the awareness around anemia much on this day in everywhere, all over the country. And FOGSI also has planned really great work this year under the leadership of Dr. Hrishikesh. And I'm really very happy that we have all the stalwarts here, Dr. Hrishikesh, FOGSI President, then we have Dr. Sharda Jain, we have Dr. Alka Kriplani, and Dr. Archana Verma, all supporting us for the cause. And I welcome them all, and we can just start our program with a traditional inauguration ceremony and lamplight. Things of Goddess Saraswati, we now begin our program, and I welcome our chief guest, Dr. Hrishikesh. We all know he is our President FOGSI 2022, and he is a founder and medical director of Bloom IVF, Chief Administrative Officer of FOGSI Manyata Project, and he is also on FIGO Women's Cancer Committee, editor of Indian edition of the British Journal of Obstetrics and Gynec, editorial board of Global Reproductive Health, a board member, that is IVF Worldwide. And he has, I think, received, this is little old, he has already received 60 plus awards, and including the honorary FRCOG fellowship. He's delivered 700 plus lectures, more than 20, I think it must have become 30 plus, sir. And actually his work speaks for him. He is really has a magnanimous heart and a really loved FOGSI president. And he has a great vision for striving the goal of Anemia Mukt Bharat. And I welcome Dr. Hrishikesh Pai sir, and I ask him to speak few words.
Thank you, Komal. Actually, I'm sitting in the because I'm in the conference of ISAR. So there are many, India is very active academically. So I'm sitting in beautiful Chola Sheraton in Chennai, where I remember when I took over as Secretary General of FOGSI, and that was a time when I think Alka madam was there in the next year. Prakash took over, and then next year was Alka madam, who is one of my favorite presidents. So we during our time we launched the Pradhan Mantri Surakshit Matrutva Abhiyan with the Pradhan Mantri. IMA that time president was Dr. Agarwal and the government of India. And we have her today, and she is very dynamic. During her time, she had also, I remember done the GCPR on and iron on nutrition or something she had done. I don't remember exactly, but we had published it also in the journal and sent it to all the people. Dr. Sharda Jain, of course, is a great lady and one of the leaders of the North. And, we have the Dr. Asmita Rathore also. So both the North Zone Societies Association is there and the AOGD is there. And, North is the heart of India, no? So, it's like, I was just telling Rishma, the other day that, it's the excitement of the North, which is very different. So, the nasha of the North is different. And that's why when and Dr. Archana Verma, our past vice president, I can't keep on taking names. All of you are there and you're all good. Dr. Komal is there and so many are there. I mean, I think I would be, ring if there is but the three chairmen who have really done, I think this program is Komal and Ritu, Kanchan Prasad, I can see Bharti, Maheshwari, Aarti Luthra, so many, Dr. Sharma, so many people are already there. So basically, I think that in short, now what we need is to give everyone iron and to deworm everyone. So if we do these two things, we'll have Anemia Mukt Bharat. And those who don't respond to the iron therapy in the hemoglobin stage less than 7, we have to do electrophoresis to pick up thalassemia. So this is in short, the whole story of iron. Iron actually, it is a reflex on development of India. So as the India becomes better and better, as people become more prosperous, then obviously they'll have more hemoglobin. People like me have got 14 hemoglobin because we are blessed by having a good life. We are well off and God has given us everything. So we have good food and nutrition, and that's why people like me have a hemoglobin of 14. Someone who doesn't have all that has a hemoglobin of 7. So ultimately it is a developmental issue. Hemoglobin or any healthcare, I feel, is a developmental issue. However, we can also counter that developmental issue by also doing simultaneous treatment in terms of healthcare. And it is more of public health, So as you know that we are having so many programs, each president does their own programs. Actually, it doesn't really, I was telling someone the other day, it really doesn't, I'm not going to be able to change the direction of this country, that only Mr. Modi and Amit Shah along with his cabinet can do it. But I can maybe, like emotionally or notionally make a difference by doing some small programs in the community, in the society, etc. And of course, keep on, the other thing we have to keep on doing is that also our postgraduate students and all, we must create more empathy, because I feel that as we are going more and more progress, they are very focused on technology, technique. I don't know. I have not yet reacted with them. So I don't know what is their feeling about nationalism, what about, poverty, whether they feel for poor people or not. I have no idea. We need to do an analysis, Komal. What is happening? What are their attitudes to overall? When we were students and all, we had this nationalism, whether they have that or whether it has diminished or whether it has increased. I think that's very important to analyze. And if it is diminished, then of course we need to, as seniors, we need to keep on telling them and focusing them that there is something called social health also. See, what is the problem now is that as we are becoming more and more advanced, our people are getting disconnected from the society. So patients feel that we have become more ruthless. So it's all interconnected. So social work and public health is very important to emphasize among the youngsters, and our professorial team has to do it. Means they are doing now work in the government hospitals because they have to do it. We must make that in the habit that no, you have to do it as a part of your responsibility. They need to. So there are too many things. I don't think I should talk about them. So I wish you the very best. And I'm having this yatra. I'm really I couldn't sleep yesterday night because see, it's something which is too large for me alone to, or for all our group who is doing the yatra to actually take on. And I've realized it, but I said, okay, now that I've taken it on, let me create the path. And the others who follow me will do it a better job, whatever I can, along with my group of chairmen, my vice president, my FOGSI members. All of us will try to create a path which others can build on. I would like to thank you for this, and I hope that again we must send that message to everyone. Just take iron, and another thing I felt that is we have to be more traditional also. I think that anything new, like someone was saying something happened, some about with iron administration. So I always feel that traditional, simple oral iron is a very good way, very good and very safe way of building iron stores in the body. So that is, we should not forget that. Thank you very much.
Thank you so much, sir. I think your vision is really very, very vast, and it is really going to get a big revolution in the country, and everybody would be really aware about their hemoglobin, and they take their hemoglobin and iron really seriously, and we will achieve. I think under your leadership, we will really reach close to reach that anemia Mukt Bharat and anemia free pregnancy. And now I call upon our guest of honor, Dr. Sharda Jain. She is actually traveling and way from to Uttarakhand. And when we had this program and we spoke, she said, for Anemia Mukta Bharat, we are always ready and we really want this program. And actually, this program is her initiative and brainchild. And she has wished all of us a great success. And she may join when the connection reaches. She's on the road to Uttarakhand. So now I welcome Dr. Alka Kriplani, madam. Dr. Alka Kriplani, we all know she is our past president of FOGSI. In 2016, she has done wonderful job as a FOGSI president. We have always admired her, and she is so humble and so encouraging whenever she talks. She has been the head of so many organizations, that is Gynecological Endocrinology Society of India, Delhi Gynecological Endoscopic Group, even the parent, that is AOGD Delhi Society, editor of Asian Journal of Obstetrics and Gynecology, and she is also the co-chair of PIGO Menstrual Disorder Committee 2016-18. Her award list is totally endless, but I think Padma Shri is something which we all look forward to, and the prestigious Dr. B.C. Roy National Award and the honorary FRCOG. I think the whole honor is with you. You have been the Vibhushan, Padma Shri for all of us. And whenever we talk about all these big honors, the name which comes to us is Dr. Alka Kriplani. So over to you, Dr. Alka Kriplani, madam. We are all eagerly waiting to hear from you.
Thank you so much for your kind words. What is a better subject than anemia? When I became president, I took the motto as preventing the preventable, and anemia was number one. And we made guidelines, we did so much effort. And Rishi was the one, as Secretary General. I said, Rishi, you have to print these guidelines. He said it is not allowed. And then with lot of effort, he published it in the journal. And I'm very thankful to him for that. But Komal, when we talk of ground reality, still I'm in private practice now, 70% of women are anemic. So what is going wrong? For years we are, blowing our trumpet and nothing is improving. So we have to give a serious thought. We have to change our attitude. We have to attack it further, as you have started. You people are doing Anemia Mukt Bharat. And this yatra and all, we should take a motto. You do hemoglobin, you will find 70% of girls are anemic. It is diet, it is faulty diet, it is in the, good socioeconomic data. It is the AUB which plays havoc. So we have to stop ambient small. we have to really revert this thing. And I think injectable iron has a big role. Oral iron is there, but injectable iron, especially in my practice, I have seen all these gynae surgeries, they are coming 5-6 grams, and you can build up very fast with such good and safe injectable irons. When we say there are side effects, see, everything has side effects, but it is very, very rare. So I think you people doing a great job. Madam Jain to has for years Anemia Mukt, even from Pune, my dear friend who was vice president with me, Shirish Patwardhan. He worked so much at 12, you should have hemoglobin 12. So we all are putting efforts, but things are not changing. We have to change our attitude, and we have to be committed as FOGSI that we will reduce incidence of anemia, improving diet, improving all the nutritional, and putting injectable iron in our practice, and not having inhibition that injectable is bad. Liberal use of injectables. I think that's the way forward. And I wish you all the best. Komal, you have been doing great work as the chairperson of Medical Disorder Committee, and the proof is that you are still on it. So it's an absolute pleasure and privilege, and wish you people all the best. I could listen to Dr. Ritu from Varanasi, and it was a pleasure listening to her voice. And there are so many people, Deepika, who from Jagsonpal, who is really, really working very hard since the COVID times for webinars. She's the
Thank you,
queen
ma'am.
of Jagsonpal. Deepika is the queen of webinars. So
Thank
I
you,
wish you all
ma'am.
the best. And thank you for the invitation.
Thank you so much, Alka madam, and for those kind and pearls of wisdom. Now I call upon our beloved member from the North Zone, and she's just the immediate vice president, and she's none other than Dr. Archana Verma, and she's really passionate about creating awareness on women's health. And whenever we want to create any awareness, she is with us. We talk about, we want to do something to aware, she is always there. And she's so focused on awareness, and I really like her dedication and determination for awareness. And so to formally introduce, she is the founder president of West UP ISOPAP chapter, also the advisor of UPCOG, organizing chairperson of UPCOG, past president of Ghaziabad Obstetrics and Gynec Society. She has also been the past chair of Public Awareness Committee of FOGSI, and her award list also is so endless. Like, she has really been dedicated for all the causes, be it from anemia to menstrual hygiene to save the girl child. The awareness which she has done is really, really great. So over to you, Dr. Archana Verma, madam. Please address the August gathering.
Thank you, Komal. It's always really a proud privilege to work with you. And Komal, you are the one person I always wanted to do anemia awareness, and we did it in big way. And you made the India Book of Record also. And now your determination, we always can see it. This is, as Dr. Alka Kriplani said, Dr. Hrishikesh Pai sir said. Yes, it is the continuum of care. If we are working together and continuously, one day दूर नहीं है दुनिया की, हम इसको conquer कर ही लेंगे. And for me, as you say, the madam said 70% of the people are anemic, definitely. But just see, I was thinking maybe I am in one and that 70%, but being with you and getting an honor to share the words with none other than Dr. Sharda Jain and Dr. Alka Kriplani. Thank you very much, Komal. And anemia, anemia to jayega to zarur jayega. We have to take care of really simple methods only. Counseling is one of the great things, because majority of the Indian women today are so much of empowered, going to gym, going to just taking part in sports and everything. They are leaders. They are working very nicely everywhere. Then what the hell is breaking that in place that their people are anemic? So this is now, I think it's a public problem, and we as a gynecologist, we need to take it as a challenge, So ये जो iron challenge को ही accept करना पड़ेगा, और we have to make it possible to reach our slogan of 12/12 and to each and every woman. And the simple thing, लिपस्टिक बिंदी लगाने को, लाल लाल कपड़े पहनने को एनीमिया नहीं कहते, एनीमिया आयरन खाने को कहते हैं. So that is a must, and it is such a simple thing. It's not a very difficult thing to eat iron. And when still with the iron things are not improving, there comes the role of this diagnosis, and again thinking of thalassemias. And also, Komal, you have today, I think your whole webinar is very good, and Dr. JB Sharma is here, who is another real icon for anemia. He is working so hard, and we have seen so many, Bharti Maheshwari from UP and Niharika, and they are the real angels for the women. They are really working hard, and देख लेना UP the number 1 आएगा anemia conquer करने पे. Thank you, and I wish the best, and that's the way we can do. Like we all are traveling, so I think Dr. Sharda Jain also, and everybody is in yatra, and we are so thankful to FOGSI President Dr. Hrishikesh Pai, and I can see our respected Dr. Yashodhara Madam also.
Thank you, Archana Madam. And this program would have not been possible without the association of Delhi Obstetrics and Gynec Society. And now I welcome the President, Dr. Asmita Muthal Rathod. She is a Director, Professor and Head at Maulana Azad Medical College, New Delhi, with a special interest in maternal fetal medicine, vaginal surgery. And she is also have 50+ publication in Index Journal, written chapters in many books, and editor of 4 books. She is also, apart from being holding positions in the AOGD, she is also RCOG North Zone member representative, expert member of Task Force of Maternal Health, GNCT Delhi, National Health Authority for all the government agencies at UPSC, MCI, NBE, ICMR. So welcome to you. I call upon Dr. Asmita Rathod. Madam, please address the audience.
Thank you so much, Dr. Komal. And I think on behalf of AOGD, my sincere thanks to you for this most appropriate way of celebrating the Iron Deficiency Day today. I think anemia is a very important contributor to maternal mortality, morbidity, and starting from a spectrum to the minor problems like an intellectual, the suboptimal performance. So iron deficiency and a treatment of iron deficiency is a key intervention which will improve not only mortality, morbidity, but the quality of life of women. Government is making its own efforts to improve anemia, and we all gynecologists, as a part of FOGSI, as a part of AOGD, if we all work together, this will not be an impossible mission. I'm sure this program of Anemia Mukt Bharat will do great with efforts of people like you who are really putting a lot of hard work in this particular area. So on behalf of AOGD, warm welcome, and thank you so much for organizing this wonderful webinar. I'm sure the stalwarts present here are going to do a brilliant job, and it will benefit all of us. Thank you so much.
Thank you so much, Dr. Asmita Rathod. And I welcome our esteemed faculties also who have joined. I have here my own sir and teacher, Dr. Rajendra Sarawgi. He is waiting here, and we are really waiting to hear him in panel, and really the entire the knowledge which he has and everything. It will be really great panel to look here and to see and learn so many things from him. And also there is a stalwart, Dr. JB Sharma. He is going to speak, and I'm really happy he's part of the program. We have our Vice President of FOGSI, the current from the North Zone, Dr. Yashodhara Pradeep also. I welcome you, madam. I know she is between 2 commitments, but we have a lecture series, and I think by the time she finishes her panel, we would be ready with our panel, and she would be the expert on the panel. So without all that, we can start with the scientific session. Deepika?
Yes, ma'am. So now to start the scientific session, we have the first session where our moderator, Dr. Komal Chavan, is going to be the first speaker. And I invite Dr. Ritu Khanna, ma'am, Dr. Ritu Khanna is Director Khanna Medical Center for Fertility Clinic at Varanasi. She is the chairperson for this session. She is the fertility specialist and endoscopic surgeon. Organizational positions she is currently holding is the chairperson for FOGSI Food and Drug Medico-Surgical Equipment Committee. She is also Secretary, Society of Fetal Medicine UP Chapter, Central Executive Committee member of Society of Fetal Medicine, Executive member of UPCOG, Scientific Secretary IMS Varanasi Chapter 2020 to 21, and she's working on exclusive single embryo transfer. She has been awarded with many of these awards, Dr. B.C. Roy Memorial Award 2018 for outstanding contribution in the field of gynae, Presidential Award 2021 by IMA Banaras for exemplary work, good work and services in the field of gynae. And she has published many papers on male and female infertility, published her first Indian study on the role of CoQ in male infertility, and presented many papers in ISAR, IFS, and AICOG, peer reviewer for JOFM and Fertility Science Research Journal. Welcome to you, ma'am, Dr. Ritu Khanna. Our next chairperson is Dr. Kanchan Prasad. Ma'am is the professor at TMMC and RC Muradabad. She's a North Zone coordinator for FOGSI CRC committee, the champion of FOGSI Awards awardee for 2021. Dr. C.S. Dawn Prize paper at AICOG.
Thank you. Thank you so much, ma'am. You can proceed.
Welcome to you, Dr. Kanchan Prasad, ma'am. And may I now request Dr. Ritu Khanna, ma'am, to please invite and introduce the topic. Invite the speaker.
Thank you, Deepika, and thank you so much to our convener, Dr. Komal, and the President AOGD, Dr. Ashmita, Madam, for having us here. A great initiative, I must say, of Anemia Mukt Bharat, and it's just an honor to have so many stalwarts all together. Sharda ma'am, Hrishikesh Pais, Alka Kriplani madam, Shodra madam, Archana ma'am, so many of us joining together to take this. Komal, it's a very, very great initiative. And the speaker today is Komal, who's a very dear friend of mine. We work together. She's done wonderful work in the committee. A very, very dynamic, humble and loving personality. And she's been the chairperson of the FOGSI Medical Disorders and Pregnancy Committee from 19 to 22. And the chairperson AMOGS Family Welfare and MTP Committee, the joint secretary ISOPA Mumbai chapter, the national expert for the FOGSI UNICEF Lakshya project, and also into the editorial board, the Journal of Global Obstetrics and Gynecology. And you had made a tremendous effort, of taking us into the Guinness record on anemia, and so many prizes to her, credit a long list, but to mention a few: Mrs. Chelja Pandit and Narayan Pandit Women Empowerment Award, the Dhira Award, the Wonder FOGSI Award, the Best Committee Award that she's done, and so many credits to her honor. So congratulations, Dr. Komal, for this great initiative that you've taken over. So handing over the mic for your to listen to you on anemia and pregnancy and the treatment options.
Thank you so much, Dr. Ritu. It is really, really pleasure to have so many friends, and colleagues here. We know today is Iron Deficiency Day, and we are definitely worried as an obstetrician that in pregnancy, its implication and its treatment. And when we talk about, as a chair of medical disorders, whenever we spoke and we talked about anemia, we found like in all the discussions all over India, it is most commonest medical disorders. Even the literature mentions it, and we are worried because of its high maternal and fetal morbidity. Almost 40% of maternal death in the third world countries are because of anemia, and even that direct or indirect, both can be because of anemia, because anemia can be present, it can occur during pregnancy. So much can be done about the complications of anemia in pregnancy. So we are always worried about anemia. The first thing which we check in a general examination, the pallor, and we check for anemia in every patient where we see. And this is a WHO definition where we know that it is a reduce in the oxygen carrying capacity. That is, it is a physiological, and it varies by sex, altitude, smoking, and pregnancy stated. So there is also a pregnancy hemodilution, which is adding on to the existing anemia. And when we check about the global burden, when we see India, the incidence is so severe. that it affects around 800 million children annually. And in India, the incidence is around 40 to almost 60%, that it is shown in this dark brown color. This is by WHO, that we are really a country which is having a more burden of anemia. And the survey which is there, that is NHFS 3 versus NHFS 4, we see that there is a declining trend, but it is not so declining, because from 57.9 it has come to 50. 50% of the people in pregnant age group, that is for 15 to 49 years, that is reproductive age group, being anemic is not going to be a good thing. Almost 50% are anemic. So this is still a huge burden, and we really have a long way forward. To classify the CDC and WHO, they all have said that anything below 11 in pregnancy is anemia. And also WHO has a mild, moderate, and severe category. And a postpartum anemia is something below 10. In second trimester, 10.5 is a cutoff because of the hemodilution changes. And FOGSI GCPR also has adapted the same kind of classification, wherein we have something below 11 is anemia, and when it is less than 7, it is a severe anemia, and less than 4, it is a very severe form of anemia. So when we talk about the average daily requirement iron, it is calculated as 0.8 milligram per D in the first trimester, and 7.5 milligram per day in third trimester. But the average dietary absorption, you see our diet, that is a Western or even the Indian diet, the diet is 0.8 to 4.5 milligram per day. So what is happening is there is definitely a deficit, and everybody will require an iron prophylactic supplement or a therapeutic supplement. So iron supplementation is a must. And causes of anemia in pregnancy, we know everything. We are going to focus today on the iron deficiency, but to sum up the list, we have our hemoglobinopathies, thalassemia, which Dr. Bhave will be talking. We have a blood loss anemia. We have metabolic disorders. We have chronic conditions also, which can lead to anemia. The immune system with anemia is going to be spoken very well by Dr. J.B. Sharma subsequently. So when we talk about anemia, we are worried about the antepartum complication, that is the preterm delivery, PPROM, preeclampsia, even IUFD, antepartum hemorrhage, heart failure, and definitely there is a guarded fetal outcome. That is, there is, because of prematurity, there can be low birth weight, there can be infection, malformations, even the cognitive development of the fetus is hampered. And there is an incidence of schizophrenia also. And there is something called as intergenerational anemia. You know that the infant who is going to be anemic is going to remain anemic in the adolescent, and then again anemic in the reproductive period. And the same person is going to be in the pregnant age group in anemia, giving rise again to an anemic infant. And then this cycle is going to continue. So we are not looking at just anemia in pregnancy, but generations of anemia. And that is the reason we need to really work and worry about the consequences of anemia. So when we talk about the diagnosis, how do we diagnose it? A simple CBC report with an MCV and RDW. That IDA is characterized by low MCV, and low MCV up to 40% with a normocytic indices, and elevated RDW, because we know this is very classical of an iron deficiency anemia. Serum iron and TIBC are actually not very reliable markers, because there is a diurnal variation of serum iron, and pregnancy itself will cause increase in total iron binding capacity. What is more significant is the serum ferritin level. The cutoff is 30 microgram per DL. And when we start, we need to know if there is a prior to starting an iron therapy, we know that a patient may be having a hemoglobinopathy or something underlying. We can do a baseline ferritin level. And when an alternative etiology of microcytic anemia is being considered, like chronic inflammation or lead toxicity or sideroblastic anemia, and if we are giving iron therapy and there is no good response, that are the patient where you do the serum ferritin level. And also in the non-anemic women, when we think that there is a risk of iron depletion or excessive bleeding or consecutive pregnancies, wherein patients have persistently low hemoglobin count. Even sometimes we are giving iron therapy, but there is no improvement in the hemoglobin levels. So that are the patients where we can do a serum ferritin and find out about the iron stores. And preferably prior to parenteral iron therapy, even to confirm the iron deficiency, if a patient is requiring a full dose of iron therapy, it's ideal time to do the serum ferritin testing. So when we talk about iron in pregnancy, this is a demand which is there. that the iron is needed for placenta, fetus, that is 500 mg, for red cell increment 500 mg. When there is a postpartum loss, there is also lactation which is going to take the drain. So total requirement is around 1,360, wherein there is an amenorrhea, in pregnancy there is going to be no menses, so 350 can be subtracted. So the actual demand is 1,000 milligrams. So that is the full iron store what we require. And how do we give this iron to the pregnant lady? That is a dietary source is one, then there is a oral, and there is parenteral. So when we talk about the dietary source, we know there is a heme iron and a non-heme iron. Heme iron is classically the protein, meat, ascorbic acid. All these factors are going to definitely increase the absorption of iron. And phytates and tannin and all are going to tea, coffee, they are going to hamper with the absorption of iron. So we need to know when we are giving the oral iron, the exact diurnal time to be taken, what to be taken, how to be taken, the iron vessels in which they can make food or have it with a lemon juice, which can increase the absorption of iron, or not to take iron and calcium together and not to have iron with food is something which we need to tell our patients when we put them on iron therapy. So when we talk about iron preparations, there are inorganic preparations. These are all the inorganic salts, that is ferrous sulfate, fumarate, ammonium citrate, ascorbate. Then there are organic, that is ferrous polymaltose. Then elemental is carbonyl iron, which was given earlier. Then the chelated iron, that is ferrous biglycinate, and technologically advanced iron salt, ferrous ascorbate. That is all what we are preferring and we are giving. So when we talk about the iron, we need to consider the status of the patient's iron stores. Then we need to know how we are going to give it, in what dose, what about the gastric acid, is it stable, the elemental iron, how much we are giving, and how much will be the bioavailability, all needs to be taken into consideration. So when we are supplementing, depending on the type of preparation, only 1 to 8% of the iron is going to get absorbed. And the absorption of the oral iron increases with increasing dose of oral iron. Only we can give maximum up to 160 milligram per day. And when we give them with some vitamin C enriched juice, it is going to be better. But we need to take care of the gastrointestinal side effect, particularly the gastritis. And iron absorption is increased in iron deficient individual as compared to non-anemic individuals. And the elemental iron content and bioavailability of supplements should be also taken. And there is no evidence that one iron salt formulation is more effective or has a fewer side effect, but it is only how the compliance of the patient is what we are more worried. Dr. Pai also pointed out, taking any form of iron is actually good, but it should be well absorbed and the patient should be compliant. That is really, really very important. Now coming to the oral supplementation, we have a WHO recommendation that is 2016, which says that around 30 to 60 milligram of elemental iron and 400 microgram of folic acid is what is recommended. And if a woman is diagnosed with anemia previously, then we can even increase it to 120, that is BD dose of iron can be given till a targeted hemoglobin of 11 is reached. FOGSI GCPR also says that when there is an established mild to moderate anemia and the period of gestation is around 30-32 weeks, we should give 100 milligram of elemental iron with 500 microgram of folic acid. And after achieving a normalization, then we can give them, maintain them in the prophylactic dose, that is 60 to 100 milligram of elemental iron. And that needs to be continued even in postpartum period. So these are the iron salts which are available. I'm not going to go in detail, but all the options what we have. And what is the benefit of the iron therapy? When we talk, it is easily available iron supplement, very affordable, best for prophylaxis of anemia in both pregnancy and postpartum period. We can achieve a targeted level even with oral. There is no need of any test dose given. It is really safe and there is not much of toxicity. So ferrous ascorbate is something which we are giving. It is a synthetic molecule. It increases the absorption of non-heme iron by reducing ferric ions and ferrous ions and preventing oxidation of ferrous ions due to ingested phytates and phosphates. So it is good, as there are a lot of studies wherein the absorption of the iron is given, and this study which shows, it is by MB Agarwal. He is a leading hematologist in Mumbai, and where he has also studied the carbonyl and the ascorbate, and he found that the hemoglobin increased of 5 gram versus 2.8 in 2 months period. So there was a significant increase in the iron by the oral iron, that is a ferrous ascorbate. And definitely it is well tolerated as it has less amount of all these symptoms which typically the iron will have. And coming to the bioavailability also is very high, that is almost 67% in IDA. So also the interaction with other iron or iron absorption inhibitors is less. It has an antioxidant properties, and it is also acts as a precursor for ferric reductase required for transfer of Fe3 to Fe2, that is the trivalent to bivalent. And almost a 1 gram rise in hemoglobin is expected at the end of 2 weeks. So we need to really counsel patient to take and take it at the right time. And also the gastrointestinal side effects are less. So the patient dropout rate and compliance and how patients will take their iron seriously and definitely take the therapy, that is really, really important when we give an oral iron, which is the higher range. Now, coming to the parenteral iron therapy, Dr. Alka Kriplani said that we really should promote parenteral iron therapy, not hesitate and give it because it is a very safe option. And when we know that there is a failure to the oral iron therapy and the patient is in late trimester, that is late second or third trimester, there is a malabsorption or any bleeding disorder, or we see that there is a postpartum anemia, these patients we should consider giving parenteral iron therapy. And there are so many studies which have shown that parenteral iron therapy is really, really beneficial. And basically, this iron therapy has a core iron and a carbohydrate shell, and this carbohydrate shell stabilizes the molecule, and there is slow release of the elemental iron. So all these IV iron agents have these complex, and there are 3 types of that. That is a type 1 complex is the FCM or iron isomaltose and iron dextran. Type 2 is a moderately strong, that is iron sucrose, and type 3 complex is a weak, that is ferric gluconate or iron citrate and iron sorbitol. So what are we commonly giving is all these whatever is available, but what is practically now given is the iron sucrose and the ferric carboxymaltose. Iron dextran, we are worried about the risk of anaphylaxis, and iron isomaltose is now there are more studies required because it is compared to an FCM, and more studies come, we can definitely take this molecule up. But what is the robust evidence that the ideal iron should behave, and that all is there in ferric carboxymaltose? It has really a less dose. You don't have to give subsequent more dose. Maximum dose can be given, and it is really very stable, and the pH also is near neutral. So IV iron, when we talk about iron sucrose, it is also, there is no test dose required. So there is no warning or something that you require to monitor the patient. There is a risk of anaphylaxis. It is not there. It can be given even repeated dose, that is 1 to 2 times a week. And how to give that, it is calculated by the Gazzoni's formula, that we calculate the iron deficit by the body weight into targeted hemoglobin minus the actual hemoglobin into 2.4 plus the iron store. And by calculating, we need to know what is the deficit, and then we need to give it in an IV drip infusion or intravenous injection undiluted. But whatever is given, it is given slowly over 8, depending on the dosage given, over 8, 15 or 30 minutes. So if you give a typically 200 milligram in 10 ml, that is a 10 ml solution in 200 ml of NaCl, then you give it for 30 minutes slowly. The only thing is you can repeat a dose, not daily, but every alternate days. As in Monday you give Wednesday, you give Friday. So we need to give repeated doses after calculation, the total deficit. You can divide the doses and provide the iron therapy. So this is what is the IV iron, which is really, really beneficial, and we can give it. But there is something called as FCM, and FCM, we know it is more absorbed, it is better, and a single dose is required. And when we talk about the FCM, we know that when we are giving a really high volume, we can give it little fast, that is even 15 minutes, and it has less reaction, and maximum effect is there. So we have a lot of studies which are also showing the safety of FCM in pregnancy, and it has a low antigenicity also. And what are the evidences are saying, and this is a common evidence which said that earlier this was debated, that usually you should confine it to the 2nd and 3rd trimester, and even if you want to give in the 1st trimester, you can outweigh the benefits and the risk. This was a safety factor. But we have our studies from our very own Dr. J.B. Sharma. He has also given, this is the AIM study, and Dr. Alka Kriplani and Dr. Nirja Batla. and they have compared the iron sucrose in pregnancy, and their FCM was given for 50 patients and 50 patients of control were given, and they find rise in HB from the baseline after 12 weeks, and they concluded that it was far higher, the rise in HB in the FCM group than in the control group, and definitely they found that FCM was beneficial in pregnancy, and it causes a rapid rise after the 12-week interval period. This is a study which I have done along with Dr. Niranjan Chavan, and here also we had 100 patients were given. We gave them FCM for anemia. They were mild, moderate anemia in pregnancy and postpartum. And when we checked their mean hemoglobin level before starting, this is the average of all the patients, was around 8.5. And then after 4 weeks, we found the hemoglobin to be around 10. So it was really a 1.5 gram rise in hemoglobin, which we got within a month's time. And also the ferritin level was measured. And there was a significant increasing in the serum ferritin level from 37 to 138. And that is the reason that showed that FCM was effective. When we talk about our Anemia Mukt Bharat guidelines, we talk about, they also recommend parenteral iron therapy as a first line treatment in mild to moderate anemia, that is IV iron sucrose or FCM. And also in a severe anemia, the first level treatment would be giving parenteral iron therapy if the patient is stable. If patient is not stable and she is having any distress, then we can consider giving the blood therapy. But IV iron, that is iron sucrose and iron carboxymaltose, are definitely can be given as per the guidelines of Anemia Mukt Bharat. So 6 interventions of Anemia Mukt Bharat are prophylactic iron and folic acid supplementation, deworming, and intensified year-round behavior change communication campaign. That is, we need to ensure and also promote delayed clamping in newborn to prevent anemia. And testing of anemia, like mass screening and digital method, that what the FOGSI is doing. We are doing this yatra and everything and doing mass screening. Mandatory provision of iron and folic acid fortified food in government funded places. And also where there are malaria pockets, and hemoglobinopathies are prevalent, you need to find out, and there are other causes of anemia and treat them. So these are the initiative by Anemia Mukt Bharat. And even FOGSI GCPR also has stated that parenteral iron therapy can be an alternative in mild to moderate anemia. And it is also recommended for severe anemia. This is a grade A evidence, and iron sucrose is actually preferred. This is all grade A evidence. And we can also give ferric carboxymaltics in pregnant women also. That is also grade A evidence. So whatever we are talking is evidence-based. There are many studies, and we can safely give iron, injectable iron therapy in our patients. This is what FOGSI has been doing, and me as a chairperson, we have done the anemia-free pregnancy campaign, where a lot of community activities and awareness was done all over last 2-3 years. And we had also the summit with the UNICEF and NIHW, API and others, and everything. We brought about the anemia change. And this is the campaign of Break Free Anemia, which we did just exactly a year ago. And today is the first anniversary of the Guinness record, which we did, and we FOGSI were in Guinness Book of Record for the pledge which we took to eradicate and break free India from anemia. And this is the Guinness Book of Certificate. And at this note, I would really like to thank you all for your patient hearing. And I would end with a quote from Amartya Sen: amongst the most important freedom that we have is the freedom from avoidable ill health and from escapable mortality. And that is what we are striving. We really don't want our mothers to succumb to anemia, and anemia should not be the cause of this mortality or morbidity what is there. And at this note, I thank you all for your patient hearing.
Thank you so much, Komal ma'am, for your brilliant elaboration. And today you gave so many important take-home messages. First is, it is avoidable ill health. We are doing so much, all FOGSians and all the clinicians, we are doing so much. Even the supplement is free of cost by the government, and it is for those who are for the pregnant lady, and for non-pregnant lady it is not very costly thing. So where we are lacking, we are not taking it seriously. So repeated emphasis by these academic and awareness program, and also few other things with you emphasize that if we are not taking seriously, we are giving rise to generation of anemic populations, and it will increase the comorbidity and seriousness of other disease. And today, the one thing which you told, that any kind of oral preparation. Take any kind of oral, whichever you like, whichever you are compliant with. And also, if the most of the time patient, we give the tablets and capsules to the patient or syrup, they are not taking it. So we have to know there where we have to intervene. Maybe we have to counsel the patient for parenteral iron. At that time, when we are seeing that patient are not serious about it, maybe we have to take that opportunity to give the patient for the parenteral iron. That is that one thing, that very important thing which you have highlighted. And Komal ma'am is doing very, for the last 3-4 years, I'm watching ma'am is doing commendable work in the field of anemia prevention, in form of academic, in form of awareness, and in form of campaigning. So ma'am, hats off to you for your this tremendous work, and I congratulate you for this this today's webinar, and I wish you all the best for the future. So I hope the fall in anemia is, as you said, it's from 57% only 50%. So we have to target to perhaps below 10%. So it is possible because of all your effort and other FOGSIans. So all the best for your future endeavors. Thank you so much.
Thank you. Thank you so much, Dr. Ritu and Dr. Kanchan.
Fantastic. Very nice presentation, Dr. Komal.
Thank you. And now we go ahead to the next talk. I think it is much awaited talk by Dr. J.B. Sharma, and I welcome the chairpersons for this talk. May I have the CVs? Yeah, I take in pleasure to call upon Dr. Bharti Maheshwari. She is a professor and head in Department of Obstetrics and Gynec at Muzaffar Nagar Medical College. She was a chairperson of FOGSI MTP committee, and we have been chairpersons together. She has done tremendous work as a chairperson of MTP committee. She's also the governing council member elect of ICOG, secretary of UPCOG, and president of Meerut Obstetrics and Gynec Society, author of many textbooks and published many papers and review articles, and also delivered the Kamini Rao oration. So over to you, Dr. Bharti Maheshwari, and to join her, I'll invite Dr. Aarti Luthra. Aarti Luthra is a dear friend and a very, I am really fond of Dr. Aarti Luthra. She's really polite and very elegant, and every time she is always very, very friendly in nature. And she is the founder and current chairperson of Uttarakhand ISAR, president-elect of Dehradun Obstetrics and Gynec Society, and vice president of Dehradun Obstetrics and Gynec Society that was previously, and currently she is also the member of the International Academic Exchange Committee of FOGSI. She has received the Champions of...
I think this is the old one. Yeah.
Yeah, I'm wondering.
Yeah, this is the old one, I think. But Komal, I know all the faculty here. Right now, I'm the president of Dehradun Society.
Yeah, because
thank you so much for inviting. Yeah. It's okay, but it's my pleasure to be in the webinar, especially with Dr. J.B. Sharma, sir.
Yeah, yes. So over to you, Dr. Bharti and Dr. Aarti.
Good evening, everyone. And first of all, I would like to congratulate Dr. Komal. And I know her for last 3 years, how she is working for the medical disorder committee, and especially for anemia. So really, Komal, hats off to you. What programs you are doing, it is really very much appreciable. And thank you for inviting me. And it is really honor to introduce Dr. J.B. Sharma, sir. Everyone knows her, his academic input, as well as his passion for work, especially in urogynecology and anemia and other diseases. So sir is a professor in the AIMS, we all know, AIMS New Delhi. And beside that, he is has awarded B.C. Roy Award. That is a very important President India Award in 2015. Beside that, we all are aware of textbook of obstetrics and gynae, what Dr. J.P. Sharma has written, and our postgraduates and our young faculty, they are very much fond of. And beside that, Dr. J.P. Sharma, sir, he has a prestigious post, committee chairperson, urogynecology, FOGSI, as well as he has won Indian Council of Medical Research Award. And beside that, he has won also the best research paper award, and editor-in-chief of Obs and Gynae today, as well as lots of academics and inputs in the conferences, as well as in the academics. So Dr. J.B. Sharma, sir, and as the topic is that the immunology part in the anemia, that is very important, because we all know that we are aware that anemia is a silent killer, how it affects not only in the pregnancy, but all maternal, fetal and other parts. So I am not doing any delay in between Sharma sir and audience. So that is Dr. J.B. Sharma sir, to you.
Very much. So at the outset, I thank Dr. Komal Chavan for inviting me here. She's a personal friend, Dr. Hrishikesh is there, Dr. Hrishikesh, Dr. Alka, Kriplani, and my respected chairpersons, Dr. Bharti and Arti, a personal friend, has been my student also. Thank you very much. And I really thank for this anemia and immune system, a little bit difficult topic. So Dr. Actually, Madam has already beautifully highlighted, Dr. Chavan has beautifully highlighted about all aspects of anemia, but I'll try to cover anemia and immune system. Next slide, please. So we all know that basically it's reduction in total red cell mass below normal limits, but by definition, which Dr. Komal has already highlighted, WHO takes some in any hemoglobin less than 11 gram, though CDC take less than 10.5 gram in second trimester, but let's keep it 11 grams, simple, very simple. So any hemoglobin less than 11 gram, and we know that it's just a tip of iceberg. What we are seeing less than 11 gram is just tip of iceberg, and most patients are iron deficiency anemia. And in spite of so much work done on anemia by FOGSI, everyone, and the sad thing is that in spite of Anemia Mukt Bharat, the last actually NFS survey has shown that incidence of anemia has gone up from 50% to 52% actually in the afterthing. And we know it's the most common medical disorder of pregnancy, and this already highlighted by Dr. Komal, 40% of pregnant women in the world, but in anemia, in fact, in India, it's almost 52%. From 50% it has increased to 52%, which is a bit sad. And India contributes to 80% of maternal deaths due to anemia and South America. Though many of them, I mean, anemia may not cause direct maternal death, but indirect maternal death is caused. Next, please. Yeah. So basically, this is what actually initially it decreased from 58% to 50%, but in the recent one, it has again increased to 52%. And almost 58% of breastfeeding women are also anemic in India. Actually, we are targeting only like 6 months of therapy because first trimester we don't treat. So ideally, we have to treat, we have to treat these in children stage, adolescent stage, if we really want to control it. Next, please. Yeah. So next slide, please. Yeah. So why does India belong to high prevalence region for anemia in pregnancy? Because of the poor eating habits, phytate-rich Indian diets, Dr. Komal also highlighted, and early onset childbearing, higher parity, short inter-pregnancy interval, lack of accessible healthcare facility, hookworm infestation, H. pylori. As Dr. Hrishikesh said, if we can deworm all people, all women, then incidence can be really decreased. Then malaria in Madhya Pradesh and many areas is important cause of anemia. Deficiency of iron in the soil and hemoglobinopathies are also like thalassemia minor is very common in North India. Next, please. Okay, so most common nutrition deficiency is iron deficiency anemia, and it is a state of negative iron balance, which Dr. Komal said in the slide also. So only 10 to 50% of total dietary iron is absorbed. So anemia is the late indicator of iron deficiency. So estimated prevalence is 2.5 times that of anemia, that means tip of iceberg. So most patients who appear to be less than more than 11 gram, even they have actually iron deficiency if you do routine serum ferritin level in them. Next, please. So yeah, so this is the same basic slide already done by us. Yeah, next please. So we know that it's a very common problem, and this also already highlighted by Dr. Komal Chavan. So almost 1000 milligram are required. Next please. Yeah. So this is the iron metabolism. I won't go into detail of that, but this is how we know that from the basically intestinal mucosa, iron is absorbed, and this milk, calcium, phytate, phosphate, they inhibit the iron absorption, while vitamin C, ascorbic acid increase the absorption, and that's why Dr. Komal said in her lecture that vitamin C, say this, citric fluid, etc., citric juice, they help in iron absorption, and some iron ascorbate, they are better absorbed, while this milk, phytate, calcium, they inhibit the absorption. And the other role of others is also there. Next, please. And ferritin helps in this thing. Yeah, next. So heme iron is better absorbed as compared to non-heme iron. Next slide, please. Yeah. So yeah, and hepcidin inhibition. So these are the iron-rich foods which Dr. Madam has already highlighted. I won't go into detail, but we know that tea, coffee, and caffeine, smoke, they inhibit the absorption, while we should eat more of iron-rich foods. Next, please. Yeah. So basically now the other topic, basically immune system, how it affects all, most things have been covered by Dr. Komal. So we know that iron is a fundamental for normal development of the immune system. Role of iron for immunity, necessary for immune cell proliferation, particularly associated with the generation of a specific response to infection. And humoral immunity appears to be less affected by iron deficiency than is cellular immunity. Iron is required for monocyte macrophage differentiation. So macrophages require iron as a cofactor for the execution of antimicrobial effector mechanism, including oxidative burst. So that means, I mean, if you see carefully every sentence of this, that means if there is iron deficiency anemia, the macrophages will work poorly. If there is this thing, macrophages and monocyte also will work poorly. Humoral immunity will be poorer, cellular immunity also will be poorer, and the immune cell proliferation, all that will be poorer. Little is known concerning the effect of clinical iron deficiency on cytokines, although it is reported that in vitro production of cytokines by lymphocyte of iron deficiency patient may be impaired. So in other words, if there is iron deficiency anemia, the immune system will not work that well. And if the immune system does not work that well, then we will be more prone for infection. And then infection will cause further iron deficiency anemia and further decreasing it. So we will go into that vicious cycle in which most of our women are. Next slide, please. Yeah, so these are the deleterious effects of iron deficiency on cellular defenses that are reversible with iron therapy. So that is important that if we give them iron therapy, then we can reverse them. But in late stage, they may become irreversible in severe iron deficiency anemia. So reduced volume of neutrophil function with decreased myeloperoxidase activity, and that's why bactericidal activity is impaired. So that means the patient will be at higher risk of developing infection, including tuberculosis, including bacterial infection. Then depression of T lymphocyte number with thymic atrophy will be there in anemia. So that means the T lymphocyte will not work that well. So the immunity basically will be poorer. Defective T lymphocyte induced proliferative response, again that means cell-mediated immunity, and the immunity will be poorer. Impaired natural killer cell activity, that means the, any microbe coming in our body normally taken care of by natural killer cell, and that will be poorer. So the more chance of infection. Impaired interleukin-2 production by lymphocytes. So again, in the deficiency of iron, I mean, this will be poorer, and then the lymphocytes will not work that well, so we'll be at risk of infection. Reduced production of macrophage migration inhibitory factor, again that will make the immunity poor. Reversible impairment of delayed cutaneous hypersensitivity, including tuberculin reaction. So again, that will make the patient poorer as various. I mean, so any microbial invasion of our body, including viruses, candida, fungi, and all of them will flourish more because that immunity is poorer in the body. So that is how, I mean, wastage iron deficiency makes the immune system poorer. Next, please. Okay, so now again, there is, because of poor immunity and low hemoglobin, there is increased susceptibility to some infection in patients with anemia. Some infection like malaria are decreasing patients with anemia. Like that is basically, I'm talking about sickle cell anemia. In case of actually in Africa in evolution, basically the cells became sickle cell that was to prevent falciparum anemia. Otherwise, I mean, most infections are increasing in there. But in sickle cell anemia, I mean, falciparum anemia is poorer because of that makes the cell sickle cell. That was the preventive mechanism. But otherwise, most infections increase in pregnancy. The odd of tuberculosis among anemic patients is 3.56. That confidence interval is that much. It is higher than non-anemic patients. So you can say that anemic patients are much more prone to have tuberculosis, and then tuberculosis itself will cause anemia. Again, the patient will go into vicious cycle. So whenever, this is important, whenever we are treating a patient of tuberculosis with anti-tuberculosis therapy, we have to treat their anemia also, like with the syrup or iron therapy. And there is increased incidence on this, LRTI, and increased severity of COVID infection in patients with anemia. It has been seen that COVID infection was more worse in case of anemic patient, and similarly, like latent low respiratory tract infections and others were also more in them. Also, flu vaccine and COVID-19 vaccines are less effective in anemic patient as immune system is affected. So this is also important that because ultimately we are giving like flu jab vaccine or COVID-19 vaccine or other vaccines. So for that, effective immune system is required. So if our immune system is poor because of anemia, then the vaccine may not be that effective. That means, in other words, the patients of anemic patients are at higher risk of having COVID-19 infection, which we said previously also. Next slide, please. Yeah, so there has been association between anemia and urinary tract infection among the pregnant women in Bengal study found. So this study found in our 200 patients, 100 women with UTI and 100 without normal pregnancy without UTI. So anemic individuals, they constitute significantly higher proportion of UTI compared to 6 versus 22%. So it means incidence of anemia was 4 times higher in UTI patient. And this is also important, like in the patient with end-stage renal patient with the other renal conditions, they are at high risk of developing anemia. And we know that patient of renal disease, chronic renal disease, in them there is blunting of erythropoietin also. So erythropoietin also makes their bone marrow hypoplastic. So they can have hypoplastic anemia also. Next slide, please. Yeah, so this is basically, so grossly, I mean, I couldn't find so much literature on the immune system and all, but that is what that, in other words, basically that anemia makes the poor immune system, anemia makes her more prone to develop this thing. And another important thing is that no, anemia makes us very, like, very lazy, very ineffective. I got patients. I mean, one patient came to me, so she was so lethargic. So this thing because, and her sister-in-law, mother-in-law said, no, she's very lazy. And this is the husband, many times they say, sir, my husband doesn't love me anymore. I said, what happened? He said, he used to sing song to Pyar Ka Sagar Hai before marriage. And now he said to Susti Ka Sagar Hai after marriage. So it was not because of this thing, it was because of anemia. So anemia can make them, and I was talking to Professor Elizabeth Lesky in Queen's Hallett Hospital, London. So she said, Dr. Sharma, just like hypothyroid patients are very lethargic and lazy, and when you give them thyroxine, they become, very effective. So same way, anemic patient, because not only hemoglobin, poor hemoglobin, but because of their poor immune system and because of cytochrome oxidase or oxidase, various enzymes are there in the brain and the body. They are also dependent on the iron. So iron is not only part of hemoglobin, it's part of myoglobin, it's part of cytochrome, peroxidase, and other enzymes. So that the minute we start them iron therapy, they become actually, a patient becomes like active, just like a hypothyroid patient becoming active after thyroxine. So hemoglobin iron also therapy has that goal. So apart from making them the patient can again become very active. She can look after her household chores. She can look after the baby after delivery. So it's very, very important to treat anemia, which doctor, this thing. And because of this will have a poor immunity. So she is more susceptible to tuberculosis. She is more susceptible to other bacterial infections. She is more susceptible to viral infections. She is more susceptible to COVID infections. She is more susceptible to flu and others. So by treating her anemia with the iron therapy and all, and making her hemoglobin more than 11 or preferably 12 gram, we can improve her immune system better. And by improving the immune system, then there will be less chances of her infection in her, less chances of tuberculosis, COVID, less chances of malaria and other infections. So that will be, we'll be winning a dual battle, which I'm very happy, Dr. Dr. Komal has done a lot of work and including Guinness Book of World Records that. So by it's a, I would say, very noble and pious thing to do, like we treat the anemia. And it's not a rocket science to treat anemia or to diagnose anemia, but all what we need to find is that, we have to, in spite of iron has been available tablet for 50 years, but in spite of that, anemia incidence came, as Dr. Alka was also saying in a inaugural lecture. So that means there is some lacuna somewhere, and probably so our aim is to, number one, basically we, the sad thing is that we deal with these patients only for 6 months in pregnancy. First 3 months you can't give iron. So it's very difficult to treat, a very narrow window period of 6 months to that. So ideally we should, when these adolescents, where the children and adults had, well, luckily we in Anemia Mukt Bharat, government is targeting adolescent girls also. So before marriage, actually the girls should have more than 12 gram hemoglobin, as Dr. Archana said, 12 but 12. So 12 gram hemoglobin, and some actresses also are saying 12. So they should have hemoglobin of 12 gram before marriage. So she should have go marry after 12 gram hemoglobin. She should have first baby after 20-21 years of age. She should have not only, she should be non-anemic, but her ferritin should also be more than 30 micropreferably. So iron stores should also be there. So then only we can conquer anemia. So aim is to correct iron deficiency, to restore iron store, correct associated complicating factor, and the choice of therapy will depend on severity of anemia, duration of pregnancy, complicating factor. And next page, so this part has already been covered by Komal. I'll just quickly go through it. So we all know that oral iron, parental iron, and blood transfusion. So what I just, this is the last slide probably. So basically, in spite of oral iron preparation, and it's not rocket science, so you can give simple ferrous sulfate tablet given free of cost in government hospital can be effective, provided the patient is able to tolerate. Only problem is that, patient is not able to tolerate, and many times by giving free medicine, they don't take them because of, toxicity, because of diarrhea or constipation. But parental iron, only 2 parental irons are allowed these days, iron sucrose and ferric carboxy maltose. Dr. Komal has beautifully highlighted. I'll not repeat that, but definitely there is a scope, and in fact, I'm giving a thesis to my PG that if we can give just 1 gram of ferric carboxy maltose during pregnancy to patient, irrespective of their oral iron intake, so they will not go into severe anemia, which is the main killer of these patients. And what is the role of blood transfusion? In fact, I'm just finishing last minute. So even erythropoietin can be given to some patients along with parental iron. And in the blood transfusion, it should not be given to pregnant ladies and all. Only indication is that If there is severe anemia beyond 36 weeks, or to replenish blood loss due to APH and PPH, or no response to oral parenteral, like we have patient of aplastic anemia, hypoplastic anemia, sickle cell crisis thalassemia major, or sometimes any like decompensated anemia less than 4 gram at any hemoglobin. Next slide, please. Okay. Yeah. Okay. Yeah. Next, please. We have already done that, Doctor. Okay. Yeah. So that deworming should be done. 400 mg albendazole should be given to all pregnant ladies with anemia after 12. Next, please. Okay. Yeah. So we have already done that. Dr. Komal done that. I don't want to repeat it. Next, please. Yeah. Next, please. Yeah. Already done. Okay. So this is important that, you know, any like suppose patient hemoglobin is 7 grams. So 14 minus 7, 7. So 7 into 250. You need 250 milligram per gram deficit. So about 1500 milligram will be required. And then iron sucrose or carboxymaltose can be done. Next, please. So just yeah. Thank you. We already done that. So if you want to give iron sucrose 200 milligram is the next. Already Dr. Komal has done it. Yes. Next, please. Next. Yeah. So there is a need basically of yeah. So already done. Thank you. Okay. Yeah. So maximum dose 1000 milligram we can give to the patient, and you can repeat up to 2 to 3 weeks of iron carboxymaltose. Next slide, please. Okay. Category C drug can be safely given in pregnancy as well as birth. Next, please. Okay. So thank you very much. So in the just last minute I highlight. So again, so anemia affects the immune system poorly. It makes the patient more prone to infection. Then anemia, and infection further increases the anemia. So she goes into a vicious cycle from which she can't come out. So we have to prevent her from going into that vicious cycle by improving her hemoglobin status. Thank you very much.
Thank you, sir. Thank you for a very clear message on effect of anemia on immune system. And as you have clearly stated that anemia is a late indicator of iron deficiency in our body. So whatever the percentage of anemic patients is, like if it is 50%, the iron deficient patients will be 2.5 times more. So it's very important to replenish iron as suggested by Dr. Pai sir in the very beginning of this webinar. And we have to understand that if there is iron deficiency, the immune system will suffer. The macrobiological activity of the cells of macrophages will be less, and they won't be having good infection protecting properties. There'll be risk of UTI, which may be as high as 3.5%, and even the risk of tuberculosis infection will be high. And a very clear message given by you is that we have to aim the treatment depending upon the amount of iron deficiency, the stage of pregnancy, and associated complicating factors. So if we start working at the grassroots, we start replenishing the iron and we detect anemia at an early stage, we do deworming, I'm sure we'll be able to further reduce the incidence of anemia. And along with that, of course, awareness is very important, as it has been constantly being done by FOGSI activities, Bara by Bara, Anemia Mukt Bharat, and now with President Dr. Hrishikesh Pai sir, we have Anemia Jagrukta Yatra starting on this Monday, and it starts from Hrishikesh. So it's my pleasure to invite all of you to the land of Pai's Ganges, from where we are starting the yatra. And we have a public health awareness camp, a public forum, and a CME. And the theme of this whole yatra is Save Nana to Anemia, Nana Anemia, and Jagrukta Badlav Yatra for awareness of anemia. Thank you so much, sir. And it's my honor to be present at your talk. Sir has been my respected teacher, and he's a great teacher, and we still learn a lot from you, sir. My warm regards to you. And congratulations, Komal, for this very important webinar, and the topics which seem of routine interest, but every time we pick up something new and we learn something great to give better results with our patients.
Thank you, Dr. Aarti. Thank you, Dr. J.B. Sharma. Thank you, Dr. Bharti Maheshwari. I think it was an excellent session, really great learning experience. And we now move ahead to the next talk. Can I have the TVs? And I welcome Dr. Kanchan Sharma. She is presently the Secretary of Kanpur Obstetrics and Gynec Society, President of IHRF Kanpur, Director and Chief Consultant of Akash IVF Center Kanpur, and she has been a member of FOGSI, IJ, ISAR, IFS, IMA, and she's really active in so many of the organizations. And she has received Pragyata Social Impact Award, Empowered Women Award, Nari Ratna Samman and Corona Warrior Award, Nari Suraksha, Nari Samman, an award from the Police Commissionerate of Kanpur. And she's a real good friend. So welcome Dr. Kanchan Sharma. And to join her, I call upon Dr. Usha Goenka.
Yes.
Usha Goenka is a consultant obstetrician at and the head of the Department of Obstetrics and Gynec at Amba Hospital, Kanpur. She's been life member of FOGSI since really long, that is 1982, and been active in so many organizations.
Presentation. Thank you
Indian
so much.
Menopausal Society.
Thank you, Dr. Komal.
Yes, madam.
It is okay. Let's listen to Dr. Bhavet.
Okay. So nice to have you, madam. And without ado, then I would like hand over the session to the chairpersons to call upon our next speaker, Dr. Abhay Bhave. He's a leading hematologist from Mumbai. I'm so happy that Dr. Abhay Bhave has made it, and he's really there to talk on a very important topic of thalassemia in pregnancy. So over to you, chairperson.
Should I introduce him?
Yeah. Please. Dr. Usha.
Yes. Dr. Bhave, welcome. Dr. Abhay
Thank you.
Bhave is MD. Dr. Bhave is MD, General Medicine, Sion Hospital, Mumbai. Fellow Hematology, Christian Medical College, Vellore, Tamil Nadu, India. He is Fellow Hematology, Royal College of Pathologists of Australia. Current designation is Consultant Hematologist, Mumbai, India. His awards are innumerous. Dr. B.R. Ramasubramaniam from Indian Medical Association Academies 2016-17. Ekta Manch Awardee for Community Services 2007. Other information conducted anemia, thalassemia detection camps, patient bleeding management, and DVT awareness programs.
Thank you for the opportunity. Can I share my slide? The chairpersons, Dr. Sharma and Dr. Goenka, thank you very much. Dr. Komal Chavan, thank you very much for the opportunity to interact with the Association of Obstetrics and Gynecology from North India Obstetrics and Gynecology Societies. So thank you very much for this opportunity to discuss a topic, I think, which is very important. And I heard with a lot of interest both the lectures of iron deficiency anemia, and I was very impressed with the depth at which it was discussed. Iron deficiency anemia, as you know, is a topic day in and day out. What we're going to discuss now is thalassemia and thalassemia during pregnancy on this very auspicious time of Anemia Mukt Bharat conclave. Yeah, so what's thalassemia? Thalassemia, nothing but hemoglobinopathies. I can't call it a disease. It's a hemoglobinopathy which comprises of thalassemia and abnormal hemoglobins, which are hereditary disorders that affect the production of hemoglobin. They affect the balance of the globin chain inside the hemoglobin. The heme and globin, the heme is made up of iron and the globin is made up of the globin chains. So if there is a change in this balance of the globin chain synthesis or its structure, then it can cause a difference called as hemoglobinopathy. The extent of this manifestation of the change in the hemoglobin would and its severity would depend upon the number of chains which are deleted. Now there are two beta genes and 4 alpha genes. So depending upon how many of the genes are affected, the manifestation of severity of the clinical symptoms will be seen in a given patient. And there are mutations within these genes. Sometimes it's not only the production which is low, but there's an abnormal production that is called as abnormal hemoglobinopathy. And you've heard of sickle cell, hemoglobin D, hemoglobin E. They're abnormal hemoglobins where the chain synthesis is adequate, but due to a mutation, their structure has changed. So the difference between thalassemias and the hemoglobinopathies also, they all come under one aegis, but there are subtle differences between them and their manifestations can also change. So beta thalassemia is when there is affection of the beta globin chain. We've got 2 genes when one member of the gene pair is affected, it is called as a carrier form, or trait in the medical term. It's called minor in the population. It has no effects on the health other than the hemoglobin being usually in India between 9 and 11. On the other hand, when both the genes are affected, then it's called thalassemia, either major or intermediate. Intermediate is when there is some amount of production of beta chains, but not adequate like in minor. And therefore, we end up getting either intermediate or major. And in this major, where both the genes are not working, the anemia is severe, and the need of transfusion is from the age of 6 months. Alpha thalassemia is the other type, which is also seen in our country, by the way, where there are 4 alpha genes, and if 1 or 2 gene deletion occurs, which is the commonest type, usually we don't see 3 and 4 gene deletions, then again you can get pictures very similar to beta thalassemia, and these are also called alpha thalassemia minor or alpha thalassemia trait. So where did this word thalassemia come from? It was coined at the University of Rochester in upstate New York by the Nobel Prize winning pathologist George Whipple and the professor of pediatrics William Bradford, from the Greek word thalassa, which means sea, and amia means in the blood. So thalassemia means sea in the blood. That means a diluted blood, what we'll call as anemia, and hyma. And is no hyma is blood, no blood or no red cells. That's how this term thalassemia has come. And for the Greeks, the sea was Mediterranean, so it was called as the Mediterranean anemia. What is the significance of thalassemia? If it's minor, people generally live a normal life. They go undetected for years, and their hemoglobin is usually between 9 and 11. Intermediate, where there's a little bit production of beta thalassemia, not completely zero, then you can get short stature, jaundice, abnormal broad faces, organomegaly like liver and spleen enlargement, and they will not need so much transfusion, little bit infrequent, but they're still in a hemoglobin which is less than 9, less than the thalassemia minor. And they may need transfusions in between. And majors, when there is no production of both the beta genes, it's called beta 0, and there the transfusion requirement is from a young age, is frequent, and as the child grows bigger, there is definitely further reduction in the hemoglobin production. They cannot interchange. Minor does not become intermediate or major. It is genetically fixed. So whatever it is, they will not interchange. Now, these disorders are detected in the Western population in approximately 4% of patients of the reproductive age. Unfortunately, we don't have data from India. In almost half of these cases, the abnormality is not evident following a simple blood examination like a CBC. It is only detected by hemoglobin electrophoresis or a gene study. So here is the role of obstetrician and why we are discussing it in this forum today. Now, if you look at the genetics of thalassemia, since thalassemia is an autosomal recessive, the heterozygous carrier states are essentially asymptomatic. They don't carry any symptoms. So they will never come to a doctor with a particular symptom which is equal to thalassemia, and therefore they'll get tested. That's not going to happen. So that's why there are many people who are unaware of the carrier state and are moving around in the general population. Now, depending upon what kind of mutation the female has, whether it's homozygous or compound heterozygous, that means it is beta thalassemia with, say, sickle cell, beta thalassemia with sometimes alpha thalassemia, beta thalassemia, hemoglobin D or E, that's called compound heterozygous state. In this situation, there can be adverse maternal outcomes because of severe anemia. There can be stillbirths, transfusion dependency, and sickling syndromes if there is a HBS along with it. Now, why do we not easily detect thalassemia? The inhibitions are high. No one wants to come out and say that they are thalassemia. No one wants to get tested for thalassemia because they're asymptomatic, especially the minors. It is the majors who are easily detected because from the age of 6 or 7 or 8 months, or maximally by 1 year of life, they are tired. The child does not carry out all the usual activity that it is supposed to carry out for the age of 6 months or 1 year. So delayed milestones is the reason why they are tested, they're found to be pale, and then they're picked up as thalassemia major. But minors usually, they don't come forward because they have really no specific symptoms. Now, the detection of thalassemia can be done in such situation, either premaritally, where we can do it in colleges, especially the degree colleges, because they are the girls and guys who are in line to get married soon. Or ethnic communities such as the Parsis, Lohanas, Kachis, Marwadis, or the Sindhis, where the incidence of thalassemia is much higher as part of their genetics. It can be done in a routine health checkup for, say, insurance purpose or for a new job or something of the sort. Or it can be after marriage, but before pregnancy, where the tests are done to see that the woman is not a thalassemia minor. But amongst all of them, I think you obstetricians are the most important, because in the antenatal care, when they come, this is the targeted population. And therefore, to prevent a thalassemia major birth, there's no one else best than the obstetrician to pick up thalassemia at this point of time when they register for the first time with you in ANC. We've tried doing testing in less than degree colleges, and what happens is that we spend taxpayers' monies through NGOs. We've done tests, we've detected thalassemia, but those people who've been diagnosed as thalassemia, they're either thrown away the report, disregarded the report, and that's why we spent a large amount of money for nothing. So we actually have stopped doing it. There's no point in doing thalassemia camps when they're going to check out your report after they have been diagnosed, and they don't give credence or value to it. So what are the inherent patterns? Why do we want to detect thalassemia? Let's take a girl who has got a beta thalassemia trait or a minor, where one gene is affected, one gene is adult, normal, one is affected. If her spouse is normal, then the progeny will be 50% of the times minor or 50% normal. So it's not going to affect the outcome of the pregnancy in terms of the fetus. So if the girl is thalassemia minor and the guy is normal, there's no worry. Likewise, if it is a boy who's thalassemia minor, but the girl is normal, there's no problem. What if a thalassemia minor has inadvertently married a beta thalassemia minor? Then what happens? There's a slight change now, which has got a huge impact. There's a, out of 4 possible options, 75% of the times you're going to get away without any problem. So 50% will be minor, just like over here. 25% will be normal. 25% will be major. That means 1 out of 4, there's a chance that that pregnancy may culminate into thalassemia major, which is something that we don't want. So in this situation, couples attending the antenatal care should be offered screening for hemoglobinopathies at their first visit according to an algorithm. Let's look at what the algorithm is. By doing this algorithm, it allows us timely prenatal diagnosis. We can give counseling about not only this pregnancy, and if it's a major, about medical termination of pregnancy, but also what to do in the next pregnancy so that they don't fall in the same problem. Or if it's later, then we can get an early diagnosis and we can treat the affected children adequately. So its role in future pregnancy also is significant. So what will you do in terms of investigations? CBC is a very good starting point, an automated CBC where you get all the indices. But alone, it is insufficient as a screening test. Yes, there are indexes over there, but they are at best kind of a prediction for having thalassemia. They're not equal to being thalassemia. So we can suspect thalassemia from CBC, and I'll tell you how. We can check the ferritin levels for a concomitant iron deficiency so that we don't miss out on it as a cause of hypochromic microcytic anemia. But your choice is going to be hemoglobin electrophoresis by high performance liquid chromatography, HPLC, where we get a raised A2, which is typical of beta thalassemia. Now remember, HPLC will not detect alpha thalassemia, it will detect only beta thalassemia. If you want to detect more the exact mutation, either of beta thalassemia or you want to pick up alpha thalassemia, we can do a DNA extraction and look for DNA mutation in that patient on the basis of molecular studies. Now, screening of at-risk patients can be from the high-risk ethnic group. If there's a past history of anemia, there's a family history of hemoglobinopathy, and this preferably should be done prior to pregnancy. It doesn't happen very often. It will be done at the time of the ANC registration more often than not. So prenatal diagnosis cannot be offered to at-risk couples unless a DNA analysis has been performed and the exact nature of the mutation can be determined. This is because if both are minors and we know their mutation, then in either chorionic villus biopsy or on the amniotic fluid cell study, we can find out from the mutation if there's one or the other mutation, it is minor. If both the mutations don't exist, it's normal. But if both the mutations are there in the same child, it is thalassemia major. That's the value of knowing the mutation. Now, this is a normal slide. These are the normal red cells that are seen over here. This is a patient with beta or alpha thalassemia trait where the cells, size of the cells is very small with a huge amount of space in between, a big space in between, indicating that it's hypochromic microcytic. And this is something you don't want to see. These are nucleated red cells. These are all hypo cells. And this is the slide of a thalassemia major child, which was born because we didn't pick it up before birth. Now we like to classify anemia. Where we come as iron deficiency and thalassemia trait is usually the hypochromic microcytic anemia, where the MCV and MCH both are low. So as a mantra, we've got for hypochromic microcytic anemia, iron deficiency anemia, the thalassemias, sideroblastic anemia, anemia of chronic disease, and lead toxicity. How do we get these MCV, MCH? It is through automated machines, which are phenomenal today. They have reached up to 7-part machines where we got measured parameters and we got derived parameters. And you can see that the hemoglobin is measured, RBC count is measured, and from these we can derive the indices on which our diagnosis is very much dependent. So what's the algorithm I was talking earlier? I would strongly recommend that in your patients who've got a low hemoglobin, look at the MCH. If the MCH is less than 27, you have a chance that either the patient has thalassemia minor or it is an iron deficiency anemia. Look at the ferritin level. If the ferritin level is normal, do a hemoglobin electrophoresis. If the A2 is high, there is your diagnosis of a beta thalassemia. If A2 is normal, it can still be a normal A2 beta thalassemia, or it can be a carrier for alpha thalassemia. And the beauty of HPLC is that it can pick up the hemoglobinopathies. That means the structural abnormalities which are there in the hemoglobin, like hemoglobin S, hemoglobin D, hemoglobin E, which also are important in pregnancy and can affect outcomes of pregnancy. In the event that if the MCH is low, less than 27, and so is the ferritin, this is iron deficiency. Don't be fooled. There might be an underlying thalassemia that is coexisting. Treat the iron deficiency anemia, and after 3 weeks of the treatment with Dr. Sharma and Dr. Chavan have said, we can do the thalassemia study and check whether the A2 is actually high or not. A common question asked to me is, if there's a patient of thalassemia trait, can they be given iron? Because we are traditionally told don't give iron. It's actually not the way to look at it. We had always said that if a thalassemia minor has no iron deficiency, don't unnecessarily give iron because the hemoglobin is low. There's a difference. But if a thalassemia minor has a low ferritin, please do give iron and bring up the hemoglobin to that level of 9 to 11, which is what is the common hemoglobin in our country for thalassemia trait. So HPLC is the one which is the most important for diagnosis of hemoglobinopathies or thalassemias. And I'll take you to the last 2 lines. The simplicity of the sample preparation, its superior resolution of the method, and accurate quantitation of hemoglobin concentration combined with complete automation makes this an ideal methodology for hemoglobin electrophoresis. There is capillary electrophoresis also, and there are other types of hemoglobin electrophoresis, but this I would say is the best way to look at hemoglobinopathies in general, whether it's thalassemia or mutations. So from here, we realized that if the A2 levels were in the range between 3.2 to 3.9, the chance of this being thalassemia is established. Over the years in India, we have decided that our cutoff will be 3.5. So any patient whose hemoglobin value is more than 3.5 A2 is considered to be thalassemia minor or thalassemia trait. In addition, based on the HPLC, which works on a charge, we can get different windows which will tell us whether there is a hemoglobin D, hemoglobin S, hemoglobin C, hemoglobin E. So our ability to differentiate not only thalassemia, but mutations is very high. So we can make several diagnoses in our patient from one HPLC, including compound heterozygous states, which can have an adverse impact on pregnancy. So we can have a printout like this. This is a patient whose hemoglobin A2 is high. This is the normal adult hemoglobin, and this is the hemoglobin F, which is also high. So these hemoglobins elute in the machine at different points of time depending upon their charge. So F is here, A adult is here, A2 is here, this is a high A2. So this is a beta heterozygous or beta thalassemia minor or trait. Over here, the F is very high, and we've got one in the sickle cell, and it is given you a value, sickle cell value. So this is a homozygous sickle cell hemoglobin SS from the same machine. And this is a situation where F is fine, A looks fine, there is no increase in A2, but down the line, there is a small band which has come up, that is hemoglobin Q in India, which comes at a later retention time of 4.78. This is seen in India. And if this marries a thalassemia minor, the resulting child can still be a major. And therefore, it's important to have a good HPLC to pick up these minor things. How do I go about the algorithm in this situation? So if I have to look at a CBC, I would strongly recommend take an automated CBC, which gives you hemoglobin, white cells, platelets, confirm that it's only anemia, and the other two cell lines are fine, because as a hematologist, for me, it makes a lot of difference. Hemoglobin, look at the 5 indices that we have. So first, look at the hemoglobin, look at whether it has to be low, look at the MCV, MCH, it's low. That means hypomicroanemia. Look at the MCV, it's less than 80. Look at the MCH, it's less than 27. Now your algorithm starts. Look at your RBC and MCHC. If they're normal or the RBC count is in fact raised, you're more likely going to be a thalassemia. Do the hemoglobin electrophoresis. If the A2 is raised, you're going to have a diagnosis of beta thalassemia. You can prove it further by DNA PCR and look at several mutations which are there. There are 6 common mutations in our country, but there are several more. If it's on the other hand, HB electrophoresis was done, it came normal, keep in mind alpha thalassemia, because the patient is still a hypochromic microcytic anemia with a raised RBC count and normal MCHC. So this could still be alpha thalassemia. You could prove it by DNA PCR. And you'll be surprised sometimes that there is something called a silent or normal A2 beta thalassemia, which can be picked up on the DNA. So when you do a DNA, you can pick up both alpha and beta mutations in the patient. So you'll be able to clearly outline whether your patient has thalassemia or not. Usually you don't need to go beyond a raised A2. It's only when both in the couple both are thalassemia trace that we need to go additionally to do DNA testing. What about on the other hand, that you have a hypochromic microcytic anemia, but the RBC count and the MCH is such that both are low. So now you've got all 5 low hemoglobin, low RBC, low MCV, low MCH, low MCHC. All 5 are low. This is more likely to be iron deficiency anemia. Do iron studies or serum ferritin. I prefer ferritin, and we can get the answer. And sometimes we have in common practice a coexisting iron deficiency and thalassemia. Treat the iron deficiency and then do the thalassemia at a subsequent date. So you can pick up lots of potential serious hemoglobinopathies through HPLC. I've labeled many of them over here, and these could impact adversely the outcomes in our patients in terms of the fetus, in terms of miscarriages, in terms of poor outcome once the child is born. Importantly, I think communication and discussion is very important. And I'm really grateful to Dr. Roshan Kola, who was retired from ICMR NIH in Mumbai, and the current Deputy Director, Dr. Anita Nadkarni, because they have been my phone a friend. And I've called them on numerous occasions to understand certain complex hemoglobinopathies, and they've been very patient and kind to inform me. And I'm happy to get calls from any of the colleagues, my colleagues, my juniors, and many of my other across the different specialties call me, and I'm happy to be part of a discussion. So feel free to call and talk to each other. A group discussion always helps when we are faced with an unusual situation. I'm going to conclude this by saying that thalassemia counseling at ANC is, I think, the most important tool for prevention of thalassemia major in children. Remember, if we don't pick it up, then there's a likelihood that a thalassemia major child will be born, and that will not be good for the community. Awareness, therefore, is very important, and we need to have a protocol of screening in ANC, like the way I told you about looking at the automatic CBC and looking at the MCH and MCV as a starting point along with the indices. Automated CBC will provide an adequate suspicion to proceed whether you are justified in spending money to do further testing. The evidence-based medicine for beta thalassemia is to perform HPLC, high performance liquid chromatography, to look at hemoglobin electrophoresis, both in terms of structural abnormalities and thalassemia, of the minor or major variety. And we can go into details with DNA analysis for specific mutation. Don't forget that in our country, anemia is predominantly 80% of the time because of nutritional deficiency, either because of iron, B12 or folate, or a combination of the 3. Therefore, we need to not only run behind thalassemia, but also look at these nutritional deficiencies and improve them, make them more proficient, and then repeat the thalassemia if it's needed. Ultimate goal is to prevent births of thalassemia progeny, and therefore provide good counseling in the antenatal care is the most important. I thank you very much for your attention. I'm happy to take your questions. Thanks.
Thank you very much, Dr. Bhave. I think you have highlighted all the very important points. My congratulations, hearty congratulations and good wishes to Dr. Komal Chavan also. She has taken this wonderfully, and she's a very good friend of mine. Sir, you have very nicely highlighted all the points. This is very important, that the pregnancy is a very important point at which we have to investigate all this for thalassemia. And thalassemia, especially automated CBC, is very important for this. As we see all the indices, as you told, they are very important. We have to do the MCH, we have to see the MCV, if all the serum ferritin level we have to do. If these levels all are low, then the hypochromic anemia. If there is a rise in RBC count is raised, in that very case, we have a suspicion about the thalassemia, and we advise the electrophoresis. That is very important, and the DNA extraction is a final thing by which we can see whether this is a beta thalassemia or alpha thalassemia. So very important message. Thank you, sir. You are a real hematologist. Very good.
Thank you.
Thank you so much, Dr. Abhay Bhave and Dr. Kanchan Sharma, Usha Goenka, for this lovely session. I think you were so good in your talk, and we have so many doubts regarding thalassemia, and you have beautifully explained everything. Thank you so much, Dr. Abhay Bhave, for sparing your valuable time with us, and we are looking forward to see you in person this evening too in a physical program. So
sure, it'll be a pleasure. Likewise.
Yes. So now, can I call upon we start the much awaited panel discussion, which is going to be very interactive and lively. So I call upon the moderator. The moderator is Dr. Ragini Agarwal. We know Dr. Ragini Agarwal as a very dynamic person from the North India. She has been the Vice President of FOGSI in 2020. We have a very close association with her, and she has been so actively involved in women's health, very focused person. Currently, she's the president of NIGF, IMA, Haryana. She's a chairperson for awareness and public health education, national convener of IMS 70+ project. She has been also the chairperson, public and social awareness of IMA 2020 to 2023, and national chairperson of public awareness committee ISCCP 2021, and president Indian Academy of Cosmetic Dermatology and Gynecology. And she's the founder of Gurgaon Obstetrics and Gynec Society, and also the founder president of Association of Obstetrics and Gynec Society of Haryana. She has received the Abdul Kalam Award for Academic Excellence, and also the Lioness Club Corona Warrior Award, IMA National President and IMA State President Award, and the Best Committee Chairperson of IMS. So welcome Dr. Ragini Agarwal, Madam. And to join her, I have Dr. Ruchika Garg. She is a very young and a dynamic professor from Department of Gynecology from SN Medical College, Agra, India. She has been working closely as a North Zone Coordinator for the Medical Disorders in Pregnancy Committee. She's really academically oriented and has been a joint editor for Journal of SAFOG MS, and also the associate editor for the Journal of Midlife Health and Secretary IMS Society, Agra. She has also recently won the FOGSI Corion Award, FOGSI Future Award, FOGSI Star Award, and many publications and academic textbooks on credit. So Dr. Ruchika Garg, welcome.
Thank you, ma'am.
Yeah, and can I introduce the chairperson? Dr. Asmita Rathod, I have already introduced. She is the president of Delhi AOGD, and she has already addressed all of you. She will be joining soon. And I welcome Asmita Mutal Rathod, Madam. And then to join her is Dr. Sujata Agarwal. Dr. Sujata Agarwal is from the IV Health and Fertility Center, Heart Gynec Clinic, Sarita Vihar, Indraprasth Apollo Hospital, Delhi. She's also the recipient of the APJ Abdul Kalam Award from DGFS, Star Icon Award Delhi Isar, Treasurer of the Delhi Isar Chapter, Cultural Secretary of DGFS, with a special interest in infertility, high-risk pregnancy. Welcome, Dr. Sujata Agarwal. Dr. Sujata Agarwal, and they are the chairpersons. And we have an expert on the panel and our very own Vice President of FOGSI, Dr. Yashodhara Pradeep, who is a professor and head of department of Dr. RMLIMS Lucknow, Senior Professor KGMU, also the Professor ELMCH Lucknow, Chief Editor of JMH, teaching experience of more than 35 years, President of Lucknow OBGY Society and Menopause Society. She was the Chairperson of Family Welfare Committee of FOGSI. She has received a Best Teacher Award and a Best Paper Award in FOGSI. Also the Chairperson of CIMT Urogyanecology. So many awards and so many positions held at various fronts in so many organizations, and more than 25 publications, chapters in books and modules. So welcome, Dr. Yashodhara Pradeep. We are very happy to have you as expert on the panel. Okay, I'll introduce all the panel, or may I ask Dr. Expert, Dr. Sujata and Dr. Smita to welcome all the panelists. Over to you, the chairpersons for the panel. Dr. Sujata Agarwal, Dr. Smita.
Thank you so much for giving me this opportunity. And this is my privilege to introduce Dr. R.P. Sarogai. He's ex-honorary president, SETI Medical College.
After seeing the degree and the portfolios of all the chairperson, I don't think it's worth reading. Go ahead further.
Welcome, sir. Niharika Malhotra. She's a known gynecologist from Agra. She's MBBS MD gold medalist. And she's consultant Rainbow IVF Center, Chairperson FOGSI Young Talent Promotion Committee, Joint Secretary FOGSI 2018, Assistant Editor General of IJHRRT. She's active member of ISAR, RCOG, FOGSI, so many committees, and she has got best awards for Yuva FOGSI Young Investigator Award in Ashray, Malaysia, President Appreciation Award by Agra Obs and Gynae Society. She has got so many publications and awards to her honor. So welcome, Dr. Niharika. Dr. Taru Chaya, she's Director, Bansal Hospital, Jaipur, and she's Secretary, Jaipur Obs and Gynae Society, member of FOGSI Breast Committee. She's her special interest in high-risk pregnancy, menopause, and uterus conservative surgeries and infertility. Welcome, Dr. Taru. And next is Dr. Sushila Gupta. She is our doctor from Delhi. She is Director and Senior Consultant Obs and Gynae, GNH Excel Medical Center, Shalimar Bagh. She is consultant also in Fortis, Shalimar Bagh. She is member of Breast Committee FOGSI, advisor Delhi Gynae Forum North since 2018, Chairperson Breast and Cervical Cancer Awareness. Welcome, Dr. Sushila Gupta. She has got so many awards and distinguished awards like Medical Luminary Award, Swasth Ratna Awards, and APJ Abdul Kalam Awards, recipient of DGF Award for Excellence in Gynecology. Welcome, Dr. Sushila Gupta. And now the next is Dr. Kiran Chandana. She is a doctor from Faridabad. She is President Obs and Gynae Society, Faridabad. Member of FOGSI MTP committee. She has got special interest in adolescent health and contraception. She is a very active member of FOGSI and Haryana Obs and Gynae, and she has contributed articles to various journals, and she has got more than 35 years experience. So welcome, Dr. Kiran ma'am. And now Dr. Anita Rajoria. She is a very known gynecologist from Delhi. She is head of department, senior consultant, Obs and Gynae. And she has got so many awards and achievements, like founder, vice president, Delhi Gynae Forum, Health Committee, AOGD, past chairperson, Reproductive Endocrinology Committee. She has got a member of Reproductive Endocrinology and Infertility Committee.
Jata ma'am, let us be fast.
So many awards, APJ Abdul Kalam.
You can just
awards.
introduce. Yeah.
And Dr. Astha, she's also from Chennai. No, she's from Maharashtra, Government Medical College, Miraj, Maharashtra. She's ex-consultant.
Thank you, Sujata ma'am.
She's got special interest in high-risk obstetrics and adolescent health and menopausal health. Welcome, Dr. Asta.
Thank you so much.
And Dr. Poonam Goyal, she is also from Delhi. She is HOD IVF Mx Hospital, Delhi.
Yes, Sujata, ho gaya, ho gaya. Ho gaya, thank you.
Okay. So let us start. Yeah, Ragini ma'am.
So over to Ragini ma'am to start the panel.
Unmute, ma'am.
At the outset, I am also thankful to Dr. Komal madam for taking this initiative and making me part of this.
And I just want to congratulate all the three speakers, and all the three talks were very informative.
Yes.
And now let's moving on to the panel discussion.
Today is the National Thalassemia Day, and having this discussion is really very, very important. And no doubt the talk by the hematologist is really wonderful. So our talk is anemia at all ages. We are going to touch from the adolescent to the menopause woman. And I request to all very, very crisp and precise answer because time is very less. We all know that anemia is a public health problem. When it is almost, we have listened in all the talks when we call it mild, moderate, and severe, and how many people are affected by it. And mostly it is iron deficiency anemia which tops the scene. As a doctor, this is our mantra that prevention is better than cure. So no doubt we are all here want to make a anemia Mukt Bharat.
So yes, without wasting the time, let us start our first case. So we have a 15-year-old girl and she presented to the OPD with 1.5 months of amenorrhea followed by heavy menstrual bleeding. And on examination, we found that she has 2-degree pallor. Hemodynamically, she was stable and there was no thyromegaly, breast and pubic hair development was okay. And per abdominal examination was also okay. On local examination, her external genitalia was normal. There was no injury such thing and bleeding was present. And per rectal examination also revealed adnexa and uterus were normal. So what are the important points in history we should take from this patient? May I know expert comments from Sarogi sir? When an adolescent girl with such symptoms come to us.
Good evening, everybody.
Yeah, welcome, sir.
First and foremost, this should be labeled as puberty menorrhagia.
Yeah.
And it is basically due to immaturity of hypothalamo-hypophyseal-ovario-uterine axis.
Yeah.
It's basically due to anovulatory cycles which occur at extremes of ages. The studies have shown that early menarche occurs in cases which are obese with high BMI, and certain environmental factors may be responsible for early menarche. Now, why I'm talking about early menarche is, if age of menarche is less than 12 years, this is for the August audience, the duration to attain ovulatory cycle is 1 year. If age of menarche is 12 to 13 years, duration to attain ovulatory cycle is 3 years. And if age of menarche is more than 13 years, duration to attain ovulatory cycle may vary up to 4.5 years. Why I'm trying to tell you this is, ultimately when it comes to treatment part, the counseling is the most important thing, and you should be prepared with the idea that this patient is likely to have anovulatory cycles more often, and if anovulatory cycles are there for 1 year or 2 years, she is likely to have these problems more frequently. Now, why in anovulatory cycle do we get bleeding? Basically, if you try to understand, there is imbalance between vasoconstrictor and vasodilator. PGF2 alpha under the influence of progesterone is vasoconstrictor, while PGE2 and PGI2 under the influence of estrogen are vasodilator. In anovulatory cycle, because there is no progesterone, there is no PG2 alpha. As a result, there is vasodilatation and bleeding occurs. What is more important again in this is, if you try to look at adolescent age, cycle frequency is normal 1 to 45 days. So again, you will have to consult the mother about the duration of flow can vary from 4 to 8 days, and volume of flow can vary from 4 to 80 days. So all these things are important as far as treatment part is concerned, as far as counseling of the mother and the child is concerned.
Yeah, Niharika, would you like to, Niharika, are you there? I got a message that she
I'm here.
Yeah.
I'm from the OT, yeah.
Okay, good. So what all points in history we have to give emphasis in this case? That she had amenorrhea followed by heavy menstrual bleeding.
Yeah, so when we are talking about adolescent anemia, we have to understand that these children will have reduced, physical development, cognitive development, and even sexual and reproductive development. So when we are taking a history, a complete detailed menstrual history with age of menarche, any problems like acne and hirsutism, and also, of course, if they are taking any drugs, and a complete family history, even a socioeconomic history here is very important, because as we see in, especially in poor developed areas or in poverty areas, adolescent anemia is very common. So a good socioeconomic history also should be taken here.
Yeah, and we should all, nowadays, we should rule out pregnancy-related bleeding, and whether she is taking any exogenous hormones, or whether she's on any anticoagulants, or whether she's having any bleeding tendencies, like epistaxis or easy bruises or petechiae, and definitely a history of hypothyroidism like weight gain and cold intolerance, fatigue should also be taken.
Can I add?
So, yeah. Sir, what anyone would like to take that? What all things we will go look for in the examination part?
For examination part, we will have to see about whether there are ecchymotic patches or petechial patches on the skin, because in other problems, bleeding tendencies when they are there. Then how much pallor is there, hepatosplenomegaly if there is generalized anasarca, any lump in the abdomen or any lump in the pelvis. And then
Also
gum bleeding is also important.
Also her BMI. In general examination, that is also important.
Yes,
just to rule out if she's too much obese or she's too thin. So both the BMI is not up to the mark. That can also actually add to the deranged HPO axis. So anyhow, anovulatory cycles, as sir said, are common in the early age group, in the early teenagers. And iatrogenic, actually, ma'am, what you were suggesting, because we have seen so many people, patients, they come at such young age and they are having a bundle of prescriptions with hormones. So that concept of starting an iatrogenic AUB kind, they just take 4 days norethistron, then they stop it. Then the patient will say again, doctor, I started bleeding. Till I'm taking the tablet, I'm bleeding free. And then this kind of thing which you pointed out.
So what investigations would you suggest any of the panelists?
Yes, ma'am, definitely she's pale. And also she is actually young, 15 years. So I will just like to run a quick blood test with the complete blood count, as was illustrated in the previous lectures. And also typing of anemia is important, which can be done by peripheral smear. We always expect it to be, because of blood loss, normo, but still we should have to rule out coexisting iron deficiency also, because in the adolescent age group, we come across, a complete mixed kind of a picture. So this is important. Then I will also like to rule out her thyroid, free T3, free T4, and the TSH, and also anti-TPO if indicated. Along with it, we have seen coexisted hyperprolactinemia is also there. So I'll also like to rule out serum prolactin. Ultrasound, because ma'am, I'm not doing her per vaginal, per rectal. Okay, I can just see if there is any prominent, any pelvic mass, but still I would just like to document it through an ultrasound report, because I might miss some loculated, some ascites, some tubercular mass, anything related, which I'm not very confident on my examination. So I will just like to have a reporting of the ultrasound. And also, ma'am, coagulation studies, the literature says that if there is no history suggestive of, early bruising or something, I will not like to give it the first go. I will not like to extensively investigate her against all the von Willebrand factors or protein C, protein S deficiencies, anticoagulant. But yes, I'll keep that in my mind, because if the patient comes with recurrent bouts of bleeding, or heavy bleeding, which are making him again susceptible to blood transfusions, I'll also like to explore those. And definitely, if I will just take her into confidence and I'll ask her if she is at all into any, she's sexually active. It's like rare in our population where we cater in India. But yes, if I'm practicing abroad, 15, 16-year-old
No, it's
girl,
not so. 50% of the girls might be.
But okay, yes, ma'am. Now the people
whenever
are
there is a history of amenorrhea, that's the
yeah,
message
UPT,
also.
that's the first thing we teach to our postgraduates. So they get a big jar if the UPT is not done, and it's now no more a taboo also, ma'am, that's correctly said. So these are the things I'll just try to take into my consideration, and for giving her a good
one more
workup.
message.
I think we can add serum ferritin also.
Yes, ma'am.
Yeah.
But actually, if the typing is normo, so I will be like comfortable in thinking that it's because of blood loss. And the peripheral smear will also give me, one like help if it's normocytic, and if it's microcytic and hyperchromic, then definitely I'll try to go for serum ferritin levels. In fact, or iron studies, TIBC, total iron binding capacities, and transferrin saturation along with serum ferritin.
Okay, and if we are going for von Willebrand's factor, there should be a gap between it and the estrogen therapy if she has been on, because these alter this thing. And if she's sexually active, always exclude any types of infection.
We can go for BTCT or APTT-PT for or platelet count. Before going for these fancy tests, ma'am, we can actually add these things in our basic workup.
Just one line of caution. Is also becoming very important, dengue, these days.
Just one line of caution: if she's sexually active, be careful. Don't forget to inform police before.
Any comment from Dr.
Sure.
Our
FOGSI, under FOGSI, we
Yeah.
have to inform. Very good point.
What's more important is
Niharika or anyone wants to take how to manage this case?
Sir is saying something.
Yeah.
more important is von Willebrand disease exists in 1% population of USA. So we can't take it lightly now. And the recent studies have shown that if lady has a persistent corpus luteal hematoma, suspect strongly von Willebrand disease.
Yes, exactly. So that has to be kept in mind and investigated if she's having all these things repeatedly or frequently.
On the management part, how to approach for such case?
Yes, for
Any of the
treatment part, basic and most important treatment in the young girls is tranexamic acid, ethamsilate, and painkiller NSAIDs. And we have to, according to the workup, we have to treat the anemia also, and what type of anemia. If it is iron deficiency anemia, then definitely iron supplementation should be done. And what pathology we are able to find out, then according to that pathology, we have to give hormonal treatment, or menstrual record can be kept so that we can treat accordingly, not hurry in giving hormone. In first basic, we can give NSAIDs and ethamsilate or tranexamic acid. And if it is not controlling or heavy bleeding, then definitely we'll give to the hormonal.
Yeah, tranexamic acid and mefenamic acid by itself reduces bleeding up to the extent of 30%. But tranexamic acid can cause increased risk of thrombosis in certain patients. I mean, those who are predisposed. So that side effect we should always know. And
would like to add here, so when we're planning or any treatment, I think deworming also should be done in such adolescent cases.
Very true. Deworming
is very important in such patients, and also giving them the right dietary advice is very important, because they should know what proper diet has to be taken, because it's just not the treatment which will work, it will also go hand in hand with her diet.
What's more important is tender, loving care. That should have been the first thing as far as management is concerned. Now, when it comes to giving ethamsilate or mefenamic acid with tranexamic acid, we generally give, I have seen prescriptions going on for 7 days, 8 days, 10 days. That's not the correct thing. What's more important is maximum you can give it up to 5 days. The reason behind it is blood loss during cycle. On first day, it is 25 to 28%. On second day, it is 45%. Third day, it is 22%. Fourth day, it is 10%. And fifth day, it is 5%. That is a natural, normal phenomenon which occurs in a normal menstrual cycle. So even if patient has heavy bleeding, you should not give it beyond 5 days as far as combination of mefenamic acid and tranexamic acid is concerned.
Yeah.
So I just want to add one more thing. Like Dr. Niharika has said regarding diet, we have to ask in history also what diet she is taking, because that is also very important. Because these days, to reduce fat, they are doing many dietary programs.
Yes. Writing also.
And for acute control of bleeding, what all can be given? In what doses?
High dose, yeah, exactly. High dose estrogen, or we can also give combined oral contraceptive pills because she's a young girl. She'll benefit. And if we can give 2 tablets of oral G together, or complete 30 micrograms of ethinyl estradiol. That is the low dose OCPs. And first we can give it 2 tablets. If the bleeding is not responding, we can give it 2, and then slowly we can taper with 1 OD, and we have to ask her to continue till 21 days. She should not stop any pill, any hormone in between. So accordingly, by seeing the effect, how is the bleeding, how she's responding, we can keep tapering the dose.
Yeah, I think better would be after doing ultrasound, we can see the thickness of the endometrium and whether it is secretory or whether it is proliferative. Accordingly, that we can add.
Say that norepinephrine is the best, to control bleeding in acute hemorrhagic episodes. So ideally, we must give norepinephrine, but if she can't afford or if we don't have that, then of course OCPs as told by ma'am. Yes.
Yeah, OCPs in, 1 tablet TDS or BD can also be given, but in such high doses, vomiting can be a problem. So additional antiemetics can be added. And even nowadays, LNG IUD is a very welcome thing in even India and abroad.
But she's an unmarried, like adolescent.
Yeah, if she's sexually active, and
then we have to
we should open our.
But even if she is sexually active, it is not open to her parents.
But sometimes patients are ready, adolescent menorrhagia, implanon can be inserted.
Implanon can.
And even DIMPA, dipot-medroxy progesterone acetate injection can also be given. And this conjugated equine estrogen intramuscular, that IV also we can give. And sometimes the patients might have contraindication for COCs, like patients might be having certain liver disorder or thrombosis. In that cases, only progesterone is the option for us. So now,
see, height will.
Can I share the screen?
Yeah, ma'am. Yeah.
When you give contraceptive
Now
pills,
we will move forward. And so from adolescent, now the girl is married, and we all know that anemia in pregnancy is a very, very common thing. Almost 52% in the low resource country and 23% in the high resource region, they are found anemic.
Ma'am, please make it full screen. Ragini ma'am.
मेरा काम नहीं कर रहा है शायद, वो फिर अटक जाएगा.
अच्छा ठीक है मैम.
कर रही हूँ. And we all know that the ID is one of the most common problem. So I asked Dr. Kiran Chandna or Dr. Anita or Dr. Taru, any of you can give this overview. What are the information on the definition of the anemia in the pregnancy?
Good evening, ma'am.
We say that it is.
Good evening, ma'am. Thank you for giving me chance for being as panelist in the esteemed panel. And according to WHO, the anemia, if the hemoglobin level is less than 11 gram% and the hemocritic level is less than 33%, the patient is said to be anemic, and the patient can be mild anemia is up 10 to 10.9%, moderate anemia 7 to 7.9%, and severe anemia if the hemoglobin level is less than 7 gram% and patient is said to be severely anemic if the hemoglobin level is less than 4 gram%. And we take the hemoglobin level, if it in the non-pregnant patient, we should take the 12 gram as the borderline, and in the pregnant patient, we should take 11 milligram%. And according to CDC, they say that in the second trimester, the hemoglobin can be taken as 10.5, and hematocrit can be taken as 32% of the hematocrit can be taken as 32%.
Okay, so thank you, Dr. Kiran. So we all know that the anemia is classified either on the basis of the etiology or morphology. We are all talking about the normocytic, normochromic, microcytic, microchromic. So anemia may be in these women because of the blood loss of any reason, or impaired synthesis, increased destruction, or that treatment may be insufficient, ineffective, or there might be some inherited loss or inherited reason. As Dr. Chandna has said, that 12 gram in the normal and the 11 gram, we all know about the physiological dilution. So most common cause of anemia is either deficiency because of the iron, folic acid. So can one of the Dr. Anita, can you tell what are the causes of the anemia? आपकी आवाज नहीं आ रही है, please unmute करिए अपने आप को.
The causes may be many, ma'am. As you have already told, it may be due to blood loss, it may be ineffective erythropoiesis, or so many. But in pregnancy, we usually encounter nutritional anemia, that too because of iron deficiency. And along with that, we can have dimorphic anemia, which is because of lack of B12 and folic acid also. Then there may be loss due to worm infestation, and there may be other causes we may encounter like thalassemia, and these are rarely, but they are not very rare. We have to be very, very vigilant. And sometimes you may have anemia with chronic diseases, like patient is chronically ill, she will have ineffective erythropoiesis. So we have to keep in mind all these things, and we have to investigate the patient accordingly.
So either there is a microcytic, normocytic anemia or macrocytic anemia. I think I will jump to the case directly instead of going with these things. So, kahan aa gaya case? Yeah. So she's third gravida, P2L2, came to the hospital at 4-month gestation for the first time. She was married for 3.5 years and her last child was 1 year old. She was breastfeeding. Her main complaint was about feeling exhausted all the time. On examination, apart from pallor, there was no other positive finding. What features in her history point to the anemia? Over to Dr. Taru.
Yeah. First, we have to take detailed history of the patient, like what are her problems. Like she is already complaining of she is having some breathlessness. So when we examine the patient, they can be pallor on examination. She is complaining of weakness. They can be palpitation. She can complain of hair loss. She can complain of headaches and breathlessness. So we have to examine the patient and take the detailed history, as it's clear here, because she's third para and she has got 2 children and still breastfeeding, and her last child is 1 year old only. The interval between 2 pregnancies is also very less. So we have to ask whether after pregnancy, first pregnancy or delivery, whether in first pregnancy she had some anemia or such problems were there or not. Then after delivery, did she take some iron tablets or supplements or not? Then we have to ask, because she is 4 months gestation, so then we have to ask whether she had any bouts of bleeding during first 3 months or not. So these are various factors that were influencing, because with her conditions, we are coming to the point that she is anemic. Then we have to do diagnosis. But why anemic? We have to go to that fact also.
Yeah. So one very important message Dr. Taru has given. One very important message Dr. Taru has given here, that after delivery, we should always tell our women, when you are breastfeeding, you should continue with your iron and calcium, because most of the patients, they stop eating it after 2 or 3 months.
There is one more missed opportunity, ma'am. This patient, this is very peculiar about Indian pregnant females we get as patients. There are chances, there are missed opportunities, like no contraception was advised to her, and she was not advised how to continue iron and B complex and calcium during breastfeeding, as you have already pointed out. So there are so many things which we are having here that are the missed opportunities.
And
So we
another
must
is advice of contraception.
Yes,
So
yes.
coming to the next question, to investigate this patient, what investigation we will ask for, Dr. Channa?
Ma'am, we will investigate this patient. We will ask for the complete blood count, peripheral blood smear, and the reticulocyte, serum ferritin level, and the red blood indices MCV, MCH, MCC, and urine and stool examinations, total iron level, serum transferrin level. We should ask for this patient, and the total what is the serum ferritin level and what is the iron binding capacity of this patient. We have to ask for this patient.
In case we find MCV, MCH low, then we can go for thalassemia profile as well in such patients.
Like in this patient, I think.
Dr. Pradeep, are you there? Dr. Yashodhara? Are you
Yes,
there?
madam, I put the message in chat box. She is leaving.
Even if we are not able to do these very costly tests, we should at least do a good peripheral blood smear and MCV, MCHC, and all facing, because these things can lead to so many,
complications in pregnancy.
Point towards thalassemia.
You will go for a iron studies. Tell me, any one of you, when you advise a iron studies in these patients?
Sometimes there could be a mixed picture, madam.
Yeah.
So in that
Your
case,
patient is not responding to your treatment, then of course we will need
oral iron conventional treatment patient is not responding.
When
Then also-
MCV and MCH are low, then we should
And
go for iron.
sometimes for treatment of thalassemia, if we want to triage whether iron is to be given to this patient or not, then we should do ferritin. If she's
Yes.
already overloaded, then we should not give iron in these patients.
Yes.
So it can be a triaging point also.
Yes, combined.
Should iron studies be done in a fasting state, or you can do it any time?
Better in fasting state.
As we have seen the iron studies, there is a diurnal variation with the diet taken, especially the rich iron diet.
We have to look after her thyroid level also, because that also leads to anemia in patients.
The very
during
important is
pregnancy.
that vitamin D level, vitamin D and the thyroid level.
Proteins level also.
Urine
So,
routine.
so quickly, one by one. So quickly, one by one, Dr. Taru, how can you differentiate IDA from the physiological anemia of pregnancy?
Because by investigations we can differentiate and what is the level of hemoglobin and what state of pregnancy we are having this. It can be physiological or pathological, because then we have and by PBF, when we see detailed PBF, then there can be different types of cells, megaloblastic also and sickle cell type also, so we can differentiate between pathological and physiological.
Dr. Sushila, what is the level of the serum ferritin cutoff for the when you thought of the giving IV iron?
Nanogram per cc.
30
nanogram per cc.
So, Dr. Asta, why does it take 2 weeks to show an increase in the hemoglobin after oral iron?
Because, ma'am, it's the erythropoiesis, the RBCs that take at least 2 weeks to form in the bone marrow. So if we have given iron treatment in the form of oral or injectable, it will take equal amount of time for the erythropoiesis to happen. So it's better always to check after 2 weeks. Otherwise, we are just wasting her money.
And also reserve will take first. And
but
later on it will show.
reticulocyte count will start increasing within 3 to 5 days. So we can do
retic count, yes.
Yeah.
So Dr. Anita, what is the way forward? Oral iron, parenteral iron, or any other idea in your mind what you can say? How do you treat your patient?
Initially, we can start her on oral iron.
Yes.
Initially, depending on her hemoglobin, we can start on oral iron. If she's moderate anemia or mild anemia, she can be given. And if she's responding to iron, then we can even give twice a day also if she's tolerating it well. And along with that, we should give her good counseling that she should take it with either lemon juice or some orange-like fruit. Because it will improve the absorption. She should not take it with tea or coffee. And what dietary advice is to begin is also another important factor. We should tell Some guidance has to be given because she might have mild heartburn or diarrhea or constipation. So we have to counsel this, but she has to continue and she has to take it regularly.
And I think it all depends on the severity of anemia
but
also.
if she is severely anemic and
She's
we
mild
want
pallid.
she
It
will
was
not
there in the
come or she is not compliant, then we prefer being in a public hospital, we prefer to give them IV iron. Yes, ma'am.
So how you will see the response to the iron therapy in this woman? How you will watch that, yes, your oral iron is working and you should
First,
continue with it?
symptomatically first, ma'am, she'll feel better. She'll have those all symptoms will go away. That
Then
first
only
day.
CBC will tell, ma'am. MCV, MCH will tell.
There's one
But
question
the
I want
first
to
thing-
ask.
Initially,
One question I want to ask.
Initial will be retic count. Within 5 to 7 days, there will be increase in the retic count.
Yeah.
We all know about this. I want to ask one thing. There's a controversy to give the iron twice a day. Everybody says the iron should not be given once a day. It is preferable even you give to the alternate day. What's the theory behind it?
Ma'am, as a treatment,
of the second tablet is very
Oxidin
less.
levels are
abscent.
Yeah, what is
Absorption
that?
of the second tablet, when we are giving first tablet, the absorption rate is comparatively high, and when giving second tablet the same day, the absorption is very, very less.
Yeah,
And
because the
some-
hepcidin levels are increased. So it's a new theory that alternate day iron should be given.
Is
In
better.
one of the study, it was found that iron absorption is increased if alternate day iron is given compared to daily iron.
but is it established, ma'am, in the it's come in the guidelines, something like that? Nothing.
There
Not
are
like
studies, but ma'am,
Not
in guidelines yet. But in
is
mild to
Give a
moderate
very clear
anemia, we
message
can
whether we
always.
should give daily or alternate day.
there is
Give a
an
very
issue
clear
with
message.
Indian women that they will not take. Even if you tell them take once a day, they will forget to take for
Exactly.
one or 2 days. So if we tell them take on alternate, they will not take for 2-3 days. I'm sure.
There's word of caution, no entry coated tablet, no time release formulations.
Correct.
So please don't follow the pharma people all the time. No oral iron in the IBD, Crohn's and after bariatric surgery,
Yes,
because
sir.
iron
Parenteral
absorption is
iron.
very poor in this patient, and there's no fun to change even the salt from A to B. So
And deworm for this patient should also.
deworming तो कर ही कर ले रहे हैं, pace off आ गया. Yes, करो,
After
करो.
20 weeks, the madam. After 20 weeks, the deworming in pregnancy.
Second trimester we can give.
Second trimester is really controversial, ma'am. It's after maybe late second trimester. After 20
Yeah,
weeks.
after 20 weeks, GOI advises that in second trimester it should be given.
Yes.
We are giving
So,
in all public
We have done the hepcidin also. Hepcidin
the best
considered
is,
the master
mebendazole.
regulator of the systemic iron
Albendazole.
bioavailability.
Mebendazole.
Albendazole.
And one thing as a precaution, what we can do a cord clamping for the prevention of the iron deficiency anemia in the infant. We have to see the iron store since beginning. Not only in the child and the fetus, even in the prenatal counseling, we have to see if mother is healthy, she has a full iron store, only then she is going to have a baby with the iron store, and that baby will grow in a manner of a non-anemic child. So over to you, Hrishika.
Okay, thank you, ma'am. Move to the third case. So we have a primey. She is 8 weeks pregnant, and she was totally asymptomatic. And this was her first antenatal visit. And these were her examination results. Her hematocrit, MCV, MCH, MCHC, सब कुछ low है. RBC count is 4.8 million, and peripheral smear is showing microcytes, poikilocytes, and target cells. So इसमें जब हमने निकाला तो Menzer index इसका 11.75 आया. So can we have an idea about her?
Suspicion of thalassemia trait is there.
Thalassemia trait most likely.
Menzer's index MCV divided by RBC. So if in thalassemia, usually RBC counts are not much affected, even they are normal or higher. So the Menzer index is actually less than 13, madam. And as opposite to iron deficiency, where RBC count is less, the Menzer's index become more than 13. So it is clear way given it's less than 13. So it's my high index of suspicion will go towards the thalassemia. So, and whereas serum ferritin is also more than 30. So 45 TIBC is also normal. Serum RN is also normal. So I will definitely like to go for HPLC. And the patient is diagnosed with beta thalassemia.
Then we will have her husband's HPLC also.
Yeah.
Okay, that is not.
That is also, it's a
that
trait.
is also positive. Oh.
So if the what we have to do, they both are carriers for beta thalassemia.
Genetic counseling.
So we have to go
genetic
for genetic
counseling
studies.
Next, we have to do the genetic
because she
studies
is 8
and-
weeks is the right time to 8 to 10 weeks. We can go for CVS in case both are
Yes,
minor.
and we have to find out whether the child is major or minor or normal.
Yeah. So the message for the audience is, if we get such a report, Menzer index is less than 13, then we should, according to the period of gestation, we should go for either for CVS or amniocentesis, or for confirmatory diagnosis for the genetic study can be done, and genetic counseling is very much required. But
If
nowadays,
patient comes to us at 8 to 10 weeks, then we have to do CBS, and if 15.6 weeks gestation onwards, then we have to go for amniocentesis.
But sometimes, ma'am, it's always better to go for amniocentesis. Sometimes, I'm not very sure, but like what others say, some fetal medicine centers, they actually returned the patient, one of my patients, and they asked her to come back at 14 to 15 weeks so that they can
Actually,
perform
because of placental mosaicism,
mosaicism has to be kept in mind. So,
Sarogi sir, can you give your expert comment, as Dr. Pradeep is not here? Dr. Sarogi sir.
The basic is ideal time to do CVS is between 8 to 10 weeks. Ideal
8 to 10
weeks. But if you miss the bus, there is no point in Korean villus biopsy, because by that time placental formation has occurred. So you have to go ahead with amniocentesis.
so just a recap.
Hello, I have joined Dr. Agni now. Just got
Yeah.
free.
Welcome, Yashodhara madam. So
About your
welcome, ma'am.
About therapy, it's based on the principle that body has a natural mechanism of absorption of iron. Whenever there is iron deficiency, you give a tablet of iron, the absorption will be maximum if there is a deficiency. So there is no point in giving 2 tablets on the same day, because the absorption will not occur. It will, on the contrary, cause nausea, vomiting. But give it on alternate day.
Okay. Can any of the panelists can take the question that how can we differentiate between iron deficiency anemia and thalassemia?
By ferritin levels, ma'am. So if both are coexisting, so we can actually go for serum ferritin. So if the serum ferritin is normal, it's predominantly thalassemia. But if serum ferritin is also low, iron stores are low, so predominantly is iron deficiency. So in that case, we can definitely give our iron tablets.
What about HbA2 level, which is
yes, ma'am,
HbA2 threshold for
severe anemia?
So actually, yeah, if it's iron deficiency, ma'am, it can show actually falsely low also. So HbA2 levels 4 to 6%. If it's more than 4%, it is go in favor of thalassemia. So it could be falsely low. It could be shown in iron deficiency anemia. So we should first correct the iron deficiency, and we should again go for a repeat test.
Yeah, very good message from Dr. Astha that HbA2 level more than 4%. So we can always think for beta thalassemia, whether it can be trait, and in cases of coexistent iron deficiency.
Yeah, Ruchi, I just want to convey this message that it is better to do one extra HPLC rather than missing any thalassemia. Because the parents who give birth to a thalassemia major baby is a big havoc in their life. So it is better to do one extra test.
Yes, and all the responsibility come to the gynecologist कि आपके पूरे फॉलोअप में चल रहा था फिर भी HPLC टेस्ट नहीं हुआ और कैसे थैलेसीमिया मेजर बेबी born हुआ. तो message for the audience is that कि HPLC testing should be a part of our armamentarium of the test, because
especially in first pregnancy.
And especially if the blood transfusion is being done, it should be done after 2 weeks.
Yes,
because sometimes these women comes at 4 or 5 gram%, and the blood is arranged, blood is transfused, and the thalassemia is thought as a second thought. And then next day, the panel is being sent. This is not right.
Okay. Yes.
Yeah.
Thalassemia now is included also, no, madam. Like it's more liberal. They are propagating it that we should have more liberal testing for thalassemia. Correct.
We should ask FOGSI to
I'll not
include
say
into the
because it depends.
protocols.
because it is not a universal testing still in the guidelines. And I'll say, please follow the guidelines. It is not, should not do unless you take a good history and you find that there is something mishap is there in the patient or in the family, something to suspect, only then you should do it. It should not be universal, because the government cannot bear this much of cost. The individual patient cannot bear this much of cost. So I'll say, take a detailed history, and if you find any suspect, only then.
So there lies the importance of doing a good CBC, a good blood picture. So
Yes.
because
Yes,
this one test will give you
and
good
iron
indices.
profile and iron
Yes.
indices, because that gives you some clue to it.
Yes. So ये हम सबको Menzer index we need to make all the gynecologists aware of it कि आप CBC की रिपोर्ट अच्छे से देखिए.
ओनली हीमोग्लोबिन नहीं देखना है, उसमें MCV, MCH, MCSC सबको अच्छे से उनका कंपैरिजन.
अगर CBC कराया है तो सब देखना ही है, खाली हीमोग्लोबिन कराया तो बात दूसरी है. You have done it CBC.
ये भी होता है, CBC कराते हैं उसमें भी खाली हीमोग्लोबिन देख लेते हैं.
नहीं नहीं, गलत चीज है, ये तो गलत चीज है.
तो यही तो अपन मैसेज देना चाहते हैं मैम.
ठीक है, ये भी आस्था ने बता दिया कि कोएग्जिस्टेंट आयरन डिफिशियंसी हो तो हाउ टू, उसको कैसे इंटरप्रिटेशन करना है. उसमें सीरम फेरिटिन लो होगा, बाकी सारे इंडिसेस तो ऑलमोस्ट वही रहेंगे, और आरबीसी काउंट जो है हमारा इसमें नॉर्मल रहेगा. अगर आयरन डिफिशियंसी एनीमिया है तो आरबीसी काउंट विल बी लो.
भावना एक वेबिनार.
So how to manage these cases?
Ma'am, we should avoid giving oral irons or IV iron without testing for other serum ferritin, as we have discussed before. So if we think that a patient is having any symptomatic anemia, we should definitely go with blood transfusions, because they respond better to blood transfusions rather than giving her, loading her with iron and getting complicated with iron or heart overloading with iron.
Yeah. So now can we get one line message from each of the panelists? So starting from Dr.
Yes,
Taru madam.
Yeah.
Okay. नहीं मैम, वो एक क्वेश्चन और रह गया है फोर्थ पैनल. चलिए रागिनी मैम.
So you continue, Ruchika. I will just read from here. So now the delivery has been done, and she has progressed towards the old age. And she has come to your clinic, a 62-year-old postmenopausal woman presented with a genitourinary syndrome and UTI. On history taking only, she told about her fatigue, dizziness, dyspnea, ongoing on stairs. Next slide, please.
Yeah.
So in older population, what can be the cause of anemia?
I think in older population, most important is the nutritional deficiencies are most important, and then autoimmune diseases, then chronic renal disease is very important. Then yes, there can be undiagnosed malignancy.
Metabolic diseases, diabetic, uncontrolled diabetic.
Files becomes very common in this age group. There may be polyps. You have to
absorption problem, gastropathy, malabsorptions.
They are usually diabetic. They take less nutrition. So all these things, you one by one, you have to rule out all the systems methodically, because this is the age group, because we might miss malignancy in these patients. They just present with simple anemia and fatigue.
और कभी ऐसे भी पेशेंट्स आए हैं जो प्रोलॉन्ग 2-2 साल से प्रोटॉन पंप इनहिबिटर्स ले रहे हैं, तो मैल अब्जॉर्प्शन हो रहा है, तो आयरन का अब्जॉर्प्शन नहीं हो पा रहा है.
B12 deficiency.
In fact, metformin is also been associated with the malabsorption of the many nutrients.
Lactic acidosis, yes, ma'am.
और आयरन डेफिशिएंसी एनीमिया के पेशेंट्स आर, दे आर मोर प्रोन टू डेवलप यूटीआई कंपेयर टू वुमेन विदाउट एनीमिया. तो ये पेशेंट भी हमारा सिर्फ सिंपल एक यूटीआई से प्रेजेंट किया था, लेकिन ऑन हिस्ट्री ही उसने बताया कि मुझे थकान भी होती है, नींद भी ज्यादा आती है, सीढ़ियां चढ़ती हूँ तो डिज्निया भी हो जाता है. तो प्रॉपर हिस्ट्री एंड एग्जामिनेशन इज वेरी मच रिक्वायर्ड.
And maybe perimenopausal phase में she must have bled a lot also, and compromised patients होते हैं, they carry on with anemia for a longer period, so we have to ask for that also.
And UTI can also present with the breathlessness, fatigue, and tiredness.
Symptomatic or symptomatic bacteria.
Yeah.
Next slide.
नहीं मैम, बस सब खत्म है.
So the now we want a message from each and every
one-liner message for the
We'll start
audience.
from the Dr. Yashodhara.
I say it was an excellent webinar, Anemia Mukt Bharat. Congratulations to Komal, she is so dedicated to the anemia. She is doing, probably this is 4th or 5th webinar in which I have come for this as expert. Otherwise, some other topic or something is been having this thing. So she is a really dedicated person and very sincere person for the anemia. So congratulations to Komal and to all the experts and to all the guests of honors.
You want
and
to give a message to the
Dr. Ragini and Dr. Ruchika and all the panelists. They're excellent. I could not hear everything because I went in between to moderate. My message is that you should always give good nutrition from the newborn. So as we give only milk, we should know that milk is not having much iron. So iron supplementation has to be done from the newborn, especially to the girl, that because it has been said, there is a cycle. अगर आपकी बेटी एनीमिक होगी, तो वो एनीमिक young woman बनेगी, एनीमिक मदर बनेगी, फिर एनीमिक बेबी को करेगी, और फिर से जो है वही साइकिल चलता जाएगा. Because I have seen many children is been diagnosed with the 6 gram, 7 gram, 5 gram, because they were only on the milk and no supplementation is being given. So
yes, food fortification is also correct.
Food fortification is good. Otherwise, you give supplementation.
Sarogi sir, are you there?
One-line message from all.
It's time to conquer anemia in order to reduce maternal mortality. That is our aim, and in order to reduce perinatal mortality.
Yes.
Did one thing that following cesarean section and following hysterectomies also, we should think of giving FCM to the patient IV when already IV going on. Give an FCM drip to the patient, maybe 1 gram of 500 milligram, depending on the requirement. Post-Caesar and post-hysterectomy, all the patients you should do that. Even post-delivery patients, you should give FCM so that they are not anemic and the cycle is broken. So it's high time we conquer anemia to reduce maternal mortality and perinatal mortality.
Okay, Taru madam.
I think whenever you come across any, either adolescent or any pregnant woman, at first visit, we should at least know by her complaints or something, whether she is anemic or not. If she is, we have to rule out everything as early as possible.
Poonam ma'am.
I think it's very important for us to counsel the patient because most of our patients are vegetarian. I think at least हम उनको इतना तो कह सकते हैं कि iron की कढ़ाई में खाना बनाओ. On Amazon, they are selling one iron fish. That is iron fish hai, something in the shape of the fish that you can put in your cooker when you are preparing your food and then take it out, wash it and keep it again. So at least कम से कम हम ये तो बता सकते हैं. And another thing important is that most of the times what happens, husband asks के आपकी दवाई खत्म हो गई है, the wife says हाँ खत्म हो गई है जी, वो लाके देता है, वो 15 दिन की दवाई लाके देता है, वो दवाई उसकी 40 दिन तक चलती रहती है. I think मतलब we have to counsel the husband and the mother-in-law all that they should also ensure that patient is taking medicine.
Yeah, Sushila ma'am.
Yes, it should start from the beginning, from the delayed cord clamping, so that starting from the neonatal, we should give more iron or more blood to the baby. And after that,
हमें hasty नहीं होना है कि cord clamp फटाफट करनी है.
Starting from the delay. And after that, whenever we are in a clinic, unless until patients, because pallor comes when patient is very anemic, below 7 or 7. So, कोशिश करनी है कि for every patient, not every patient, if hemoglobin, at least हम hemoglobin करा दें, या frequently सिर्फ hemoglobin camp हम frequently अपने clinic पे लगाएं, so that we can detect more and more anemic patients and we can correct anemia, because कराते नहीं है. जब हम कहते हैं CBC या पूरा proper कराओ, they don't go for the testing. तो सिर्फ hemoglobin भी अगर हम करा लें, पेशेंट्स का मास में लाइक कैंप्स लगा के फ्रीक्वेंटली, और वहीं पे उनको अवेयर कराएं कि हीमोग्लोबिन शुड बी मोर। फिर उसके बाद में कंप्लीट सीबीसी एंड ऑल। लाइक मेरे क्लिनिक में बहुत सारे एमआर बार बार आते हैं जो आयरन, मतलब दे सेल आयरन एंड दे फ्रीक्वेंटली कीप कैंप, और वहीं पे हीमोग्लोबिन बता के चले जाते हैं। तो दैट पॉलिसी कैन बी अडॉप्टेड टू कवर द मास।
Three times each trimester should have a hemoglobin.
Yes, definitely. प्रेगनेंसी में तो जैसे ही प्रेगनेंसी आता है, बिफोर प्रेगनेंसी इफ हीमोग्लोबिन इज बिलो 11 or below 12 any, we should consider as a anemia and we start investigating and treating antenatal patients. But otherwise जैसे रूटीन कोई भी अगर पब्लिक में हमें अनीमिया मुक्त भारत करना है, तो इन द ओपीडी, इन अ जनरल ओपीडी बेस पे अगर हम सिर्फ हीमोग्लोबिन करवाना फ्रीक्वेंटली शुरू कर दें पेशेंट्स का, मोर एंड मोर पेशेंट्स शुड गेट इट डन एंड दे आर अवेयर कि अनीमिया भी कोई एक चीज होती है।
Niharika, are you there? Would you like to give one line message?
I don't think she's there.
Okay.
She has left.
Can I give one line message?
Anita ma'am.
Yeah. I just wanted to add that we must keep on checking the compliance of the patient also. So that is very important. Just giving them iron tablets is not enough, because I have seen they are distributing the tablets to the family members also. Ki ek tu kha le, ek main kha lu. This should not happen. We should keep on checking compliance, and we should not forget to deworm these mothers, especially in second trimester. It should ideally be done in all the patients. And one must be very, very careful. If she's not responding to your iron therapy, please check what is the cause. Keep on counseling her. What are the factors which may hinder the absorption of iron which you have given to her? So all these things are very, very relevant in following up the patients of anemia with pregnancy.
In fact, parental iron also.
Ruchita,
Patient is
not.
I
am
sure it must have been discussed. For the compliance, you should keep on asking what is your stool color. So you know that patient is taking iron. Otherwise, you cannot check. Because yes, I take.
Yeah.
So it is the stool color which is the most important thing.
डॉक्टर यशोधरा, हम लोग सब हीमोग्लोबिन के लिए ग्लोबिन को तो भूल जाते हैं, सिर्फ आयरन देते जाते हैं। We should think about the globin also, कि what type of the protein they are taking, whether it is sufficient or not. Only iron cannot make the hemoglobin.
Yes, of course.
Indian diet is very much lacking in proteins. We have a carbohydrate-rich diet.
So when yes, ma'am. For me, I would like to just say, patients, ma'am, from adolescent to reproductive till menopausal, all women should be. I always see the tongue, even if she is coming for white discharge, leukorrhea, because what kind of patients we come across is, madam, they are 6-7 grams, but they are doing all household works without any crimping, without any grumping. So they just, the body gets adapted.
Average hemoglobin is 5.
To say so that as soon as patient enters your clinic, your examination starts there only.
Exactly.
You can, very well make out whether your patient is pale, she is frail, walking slowly, is
because ma'am, it is so commonly
very, very particular. As soon as the patient entered the OPD, he will say, Dr. Anita, tell me what is the diagnosis of this mother. So all these things are your observation can be very important too.
Exactly. So ma'am, that's what I was thinking, that we should always consider this as a common problem for all females. That's from adolescent till menopause. So it is because some patients, they don't come across only ki they are having some problem till we get their investigations done. So one thing, and another thing is, ma'am, as we were discussing, we should take the husband in the loop, and we should also take the mother-in-laws and all these, caretakers in the loop, because in pregnancy, usually they give so much diet restrictions to these patients. And after delivery, she's feeding, she's having so low BP, but still she's not fed with, normal healthy diet. पता है जैसे spinach है या कुछ हरी सब्जियां हैं कि बच्चे को ये हो जाएगा वो हो जाएगा. Fruits नहीं देते, madam. They don't give anar, they don't give apple. जुकाम हो जाएगा रात को. So this kind of practice is so common in our society where we cater. So और हम patient को बोलेंगे तो वो बोलेगी हमें तो kitchen में जाना ही allowed नहीं है, हमें तो सब वो खाना जो मिलता है हम वही खाते हैं. So this thing also I think has to be kept in their minds कि please आप सब खाना खिलाइए, अंडा खिलाइए. High protein rich diet is so important. As madam has said, full family counseling नहीं लेते. So that is also important part, ma'am, which I
That
what
is
Ragini
why
ma'am said.
concept of postnatal clinics are coming.
Very correct.
That is where
Postnatal
we
clinic,
must
and
keep
husband
on
should also
following.
accompany there.
Yeah.
What I say,
When the child
contraception,
is being, yeah, when the child is
interpregnancy
being brought
interval.
for immunization. Yes, ma'am.
Exactly. So interpregnancy interval has to be dealt, has to be talked with the couple in detail. So that also goes a long way in improving the female's health at whole, at large, not
And
only
school
jacha
girls,
bachcha health.
school
Yeah,
girls
school
को भी
girls.
iron supplementation start कर देना चाहिए.
बिल्कुल बिल्कुल. And this is
Supplement,
coming, ma'am,
tablets.
in so many programs in adolescent health. Actually, it's being promoted, so it's a good step.
रुचिका, आप अपना ये शेयर बंद कर दीजिए जिससे कि सब लोग
हाँ, सबकी शक्ल better दिखे.
I just want to add,
stop also.
If the patient is not responding to oral iron, we should give her parenteral also.
Yeah.
बहुत सब लोग डरते हैं कि IV नहीं देंगे, पर डरने की कोई भी जरूरत नहीं है. It's very safe.
On the OPD basis also she can take.
Give parenteral iron. Don't wait after 30 weeks. If she is taking iron from second trimester, from 12 weeks, and still her hemoglobin.
Sujata, you are very right. We should give parenteral iron, but we should take a consent before giving iron.
Consent or वो तो precautions we have to take. Everything we have to take. Consent, proper emergency.
Reconsider also. We should reconsider diagnosis also. If she's not responding to oral iron, we should just rule out if compliance achhi hai. Still, if she's not responding, then we have to look out maybe some other causes also as well.
But we have to counsel that IV iron will also take some time.
Same time, exactly same time it takes.
7 बजे ऑर्गेनाइजर कह रहे हैं खत्म करो.
और लास्ट थिंग, अगर मदर इन लॉ पूछती है कि इसको क्या खिलाना डिलीवरी के बाद, मैं बोलती हूँ जो आपका बेटा खा सकता है,
जो खुद, जो वही बेस्ट आंसर है, जो आप खाते हैं वही खिलाइए.
बस और कुछ नहीं.
हम पानी भी नहीं पिलाते.
अगर खाना जो लग के आता है प्लेट में, अगर अलग अलग खाना है तो हस्बैंड वाइफ एक्सचेंज करेंगे प्लेट.
गुड आइडिया.
अगली बार से ना हमारे क्लिनिक पे ही नहीं आएगी.
यही बोलती हूँ कि अगर तुम्हारे मर्जी का खाना नहीं दिया तो
ऐसा नहीं है, कहीं ना कहीं कुछ डिफेक्ट ज्यादा है. नहीं तो आजकल जो है, जो हमारे पुराने जमाने में जो खाना देते थे, सारी इन लोगों को ये हरी मूंग की दाल का पूरा बाउल मिलता था. हम अपनी ओर से कह सकते हैं स्ट्रेस करके कि आपको ये खाना है और ये बेनिफिट होगा. और अगर आप उसको मिल्क से जोड़ देंगे और बच्चे के दिमाग से जोड़ देंगे ना, तो कोई भी जो है मदर इन लॉ बहू को खिलाने से पीछे नहीं हटेगी, क्योंकि उसको अपने वंश का ख्याल रहेगा. आई थिंक वी हैव टू बी लिटिल स्मार्ट टू कन्वे दैट व्हाई वी आर गिविंग सो मच ऑफ द डाइट.
Thank you. Thanks to my all panelists.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you very much for being here today.
Thank you, Bharti, ma'am.
So Jagsonpal brings to you iron therapy, which is JP-tone iron syrup, which is enriched with zinc and vitamin B complex. Do try our age-old with JP-tone iron syrup. Also, we are very proud to announce to you that Divatron, our dydrogesterone 10 mg tablets, have been the first runner-up award at AOX Marketing Excellence Awards Night just this week.
And the first runner-up is Divatron from Jack.
So thank you all very much for making Divatron an award-winning brand. Also, we bring to you Doxypal DR-L. And thank you all